I wish to congratulate to all our mentors, conveners, and co conveners of the workshops for making an excellent scientific program for these workshops. I would like to thank to all our listeners, and I hope at the end you will take home important messages which will help you in future practice. I declare now the workshops open. Long live IFS.
A very warm good afternoon to all of you. Welcome to an exciting workshop which is going to be filled with empowering, inspiring, and beautiful thoughts. To inaugurate the workshop, I'd like to call upon Dr. Gauri Devi ma'am. Her credentials and virtues are impossible to summarize in a few words. Still, she has been, I'll just share the screen. She has been the past president of Indian Fertility Society of 2018 to 2020. And as a very senior consultant in the field of infertility, I'd like to now call upon ma'am to inaugurate the workshop.
Good afternoon to all of you, the faculty, the delegates who have joined in, all the chairpersons and speakers. It's indeed my proud privilege to welcome you to this workshop on counseling in ART, which is part of the 16th annual conference of Indian Fertility Society and first virtual global conference for Division 2020. Counseling is an integral part not only of ART but infertility itself. It has a lot of social and psychological stigma attached to both infertility as well as ART, pre-treatment, intra-treatment, and post-treatment. The counseling is very important in all these. Now, to work on this as a workshop, we have national as well as international faculty giving us the inputs. Ms. Joanne Covardini from United Kingdom, Mrs. Sandra Bateman, again from United Kingdom, and the both of them are very senior psychotherapists. And we have Dr. Sofia Gamero, who is a chair of Esri Psychology and Counseling SIG group. I welcome a warm, I uh, put forth a warm welcome to this international faculty. Besides that, we have got renowned Indian speakers. Ms. Poonam Nair, who is the chair of SIG of Counseling IFS, and also Dr. Reema Dada from All India Institute of Medical Sciences, Shri Yash Shekhar, healer, astrologer, motivational speaker, besides Megha Tulyan, Mirambika Mahapatro, and all, and a panel discussion by a specialist moderated by none other than Dr. K.D. Nair, who is our President-elect IFS, and Anupama Badur. So I welcome all of you to this interesting workshop, an essential workshop and counseling and ART. Now I request Dr. Poonam Nair to take over to give you a sort of an overview about this workshop. Dr. Poonam.
Okay, first of all, I'd like to welcome all of you. I want to show some PPT, if you can remove this biodata slide. So, okay, we will. Okay. And thank you so much for giving me this opportunity to to work as a team with so many people. I've learned a lot, and it's been a wonderful journey all through. This effort to develop psychology in the field of infertility is so vital, because probably this is the only field of medicine where the problem does not cause the death. If it is unhandled, a person without a child lives. But there can be such a severe social and emotional repercussion that it is this emotional impact which can destroy the person. So, as much as it is necessary to put in the knowledge of gynec and medical sciences into it, one cannot, at least at this stage, forget the emotional cost to the person who has entered your clinic. And we have a responsibility to as scientists with evidence base, long years of research, to care for them and guide them in the best possible way. Now, this is that in developing countries, there is a severe consequence of infertility, economic deprivation, social isolation, murder, and even suicide. And even in the developed countries, you cannot ask somebody, why are there no children in your life or in your relationship? It is culturally unacceptable. And this is something surrounded in secrecy and privacy, even in high income and high educated societies. So, this is an emotionally charged area. And this art, on the other hand, is based on the medical knowledge. There is a wonderful team of clinicians like you, embryologists, nurses, who are doing such a good job. But the state of art is that the success rate is 25 to 30%. That means 70 to 75% of people who are coming into your clinic, they are going to go out without the child. Just imagine, they came with a burden. They spend 4 to 6 years of their life searching for to fulfill that desire, and with the best ethical, with the best practice, with the best science, 70 to 75% went out empty handed, and in a country like ours, financially depleted. And the consequence, if you leave it like that, are quite horrific. The mental illness escalates to about tenfold in these people. So, at least if we are not able to give the baby, let us at least help them in this aspect. So, this was, the failure became very devastating, because originally it was a stressful condition. On top of it, the stress of the journey. And we are starting from diagnosis cycles to the end point. It's a very long journey. I don't think there would be any disease which requires such a prolonged ongoing interaction filled with so much uncertainty. I'm not a doctor, so maybe I'm wrong, but as far as I know. So this workshop, now the infertility field has taken in so many different types of cases. So along with it, the psychological dilemmas have also multiplied. So there are now things like third party reproduction. Reproduction was meant to be two party. Now we have a third person here. So even after the child is born, I don't know what it feels like for a mother to know that the child she is bearing comes from another's genes. They keep on thinking about it for a long time. What does the father feel if the child that is come in has come from another man? What is his emotional bonding? So all these have long term repercussions. So in addition to that, we'll be looking at the social construction of infertility, changing needs of patients, how does one break bad news. An in-depth understanding of grief process will help you to know why it is necessary, so essential, to have a protocol for breaking bad news. And is stress only there in the patient? What about the poor doctor? He works so hard. What about him? So can yoga help, and in what aspects? So these are some of the things we hope to cover, and much still remains uncovered. with this, I'd like to welcome you all once more to be with us for this workshop. Thank you.
Okay.
Okay.
I'd like to now call upon our chairpersons for the session.
Okay.
First one in, Dr. Kavita Bhati, Professor and Head of the CMC Ludhiana, having many awards and accolades to her name. Dr. Vandana Narula, Senior Consultant Obstetrics and Gynecology with special interest in infertility, being a President-elect of IMA Gurgaon. Dr. Suman Bishnoi, a practicing gynecologist with interest in infertility, retired from MS Civil Hospital, serving the Haryana government for almost 22 years. And Dr. Rakhi Malhotra, Director AAS Fertility, AS Fertility and Maternal Center, Rohtak, Haryana, who's also the Joint Secretary of ISAR Chapter Haryana and Obstetric and Gynecology Society, Haryana. Handing over the session to the chairpersons now. Dr. Kavita Bhati. Yes.
I think I'll take over now. We all know the times are changing, so we should also understand the changing needs of the infertile couple, and we have to adapt to all this. And for the next talk, which is by Dr. Megha Tulsiyan, she speaks on dealing with the grief reaction, the protocol for breaking the bad news, which is actually very difficult to do. So I'll introduce Dr. Megha Tulsiyan. Is she here?
Yeah. First speaker मैं हूँ. वंदना नरूला ने मेरा बोल दिया.
Acha, Dr. Poonam, you are the first speaker?
Yeah.
Please
Yes, I am.
introduce.
Okay. All right. I'm uploading my slides. Just. Mhm. Okay. Welcome, everybody. And I'll be talking about the changing needs of the patient from the time when the couple enters your clinic to the time he finally exits at the end of treatment. I will be covering some parts of it. It's too vast a subject for me to cover alone, but the very important part will be covered later by Dr. Megha.
Please introduce Dr. Poonam, who is there to introduce her.
Shall I introduce her?
Yeah, Dr. Kavita, please do so.
Is Kavita around? Otherwise, I am Gauri. I can introduce her. No problem.
Ma'am, please.
So it's a great pleasure to introduce Dr. Poonam Nair. She's a very senior psychologist, and she is a psychologist working with Akanksha IVF Center. She has many publications to her credit. Dr. Poonam Nair, please take this.
You just need to slideshow.
I'm screen sharing. Can you see the PPT?
Yeah, we can.
Okay. Okay. It's now here. This discussion is based on ESHRI guidelines of 2015, and this is a compilation of more than 25 years of research, which was done across the globe. All the evidence-based practices were summarized. This book is available online. Anybody can download it, and it is there. It's a very good comprehensive guide. I will be covering the needs of the patient. There are two aspects covered in the guide, which is the preference and the needs. I will be focusing on the needs. Now, patient's needs are, these are the needs which patients experience across the treatment, and we have to detect and address the needs, how they are. Just excuse me, I think the wrong, can I just stop sharing 1 minute? Just 1 minute. The editor. I'll just. Sorry, this, I was just editing it and then wrong one has come. I'm sorry about this. Basically, we will be talking about, first of all, how the patient wants to be treated. But this is an area where you can ask, how do you want to be treated if you visit a doctor? So basically, these are core values which are required in any human transaction, which is defined as patient-centered care, where the things like empathy and sensitivity of the staff, the sensitivity to emotional needs, and it has an impact that all this actually affects the
Your screen is
disturbs the
not showing.
patient, lack of empathy.
Sorry to interrupt. Your screen is not showing.
My screen is not showing, but I
Yeah.
can see it. I can see mine.
You share again.
Okay, I'll share again. Okay. Just 1 minute. Just 1 minute. I'll.
Just click on share screen.
Just.
Ma'am, if you have any problem in connection, so can we start with the next talk till the time she's okay with the.
Yeah, do that. I'll just, there is, although I've got this 4G thing with me, but it's.
Okay, so Megha Tulsian is here.
Yeah, please.
Yes. So, Chairperson, please introduce Megha Tulsian so that we can
Yes.
start with the next session till that Poonam ma'am is ready with the talk.
Just 1 minute.
I think
So
Vandana already did that.
Yeah, I'm trying to do it now again. We have Megha Tulsian, who will be dealing with the grief reaction, the protocol for breaking the bad news. And she is a founder of I Reflect Counseling and Psychotherapy Center, which is based in Mumbai. Over 13 years of experience in the field of psychology. She is PhD psychology on the emotional needs of couples undergoing treatment for infertility. I never knew you had a special topic like that. And speaker at workshops, international conferences on psychological aspects of infertility. And she has an international certification of CE, CBT, and ISP, and lifetime membership of Bombay Psychological Association. So we welcome Dr. Megha Tulsian.
Thank you, Dr. Vandana. Am I audible?
Yeah, you are.
Okay. So, good afternoon, everyone. I'm going to be talking about dealing with the grief reaction and protocol for breaking bad news in the context of ARD. Now, it is extremely important to understand the grief reaction in the context of ARD because there is a sense of loss at various levels in infertility and in assisted reproductive technology. A lot of this loss is actually invisible. and hence the grief is also invisible. Now, in general, we associate grief with death, but in totality, grieving is a response to any kind of loss. And in infertility treatment, there can be a deep sense of loss at various stages of the treatment, starting from just getting to know that a couple may not be able to have a biological child naturally. So it's almost like the death of the dream to have a biological child by through natural ways, and then which keeps ascending in various ways as treatment progresses. There is also a loss of bodily integrity that they can be feeling, where they feel that the women especially can be feeling that their body has failed them, or in case of male factor infertility, even the men could be feeling that their body has failed them. Then there is also a sense of loss of identity, because their ideal self could be men and women who can become mothers and fathers, whereas their real self is infertile. So it's almost an identity crisis that they can go through. So the process of receiving and adapting to this news at various levels can be a very painful process. And that gets complicated further by the fact that on the surface, life seems to be the same as before. In case of very tangible losses, such as death of a loved one, there are many rituals that we have to help process death, to help handle the loss through people meeting and various rituals. But there are no rituals that exist for such invisible losses. And hence, as clinicians and as counselors, it becomes very important at our level to understand that these couples could be grieving and they could be facing losses at many levels, and that we need to be sensitive to that grief. Now, the bad news in assisted reproductive technology is a very frequent occurrence. It's not just a one-time thing. It begins from the infertility diagnosis itself, and then there are various stages in which there can be failures in the treatment, then sometimes the clinical ineffectiveness of the treatments. Then there are special situations where we have to break the news of a need for a donor, a gamete donor, or a egg donor, or a sperm donor, or the need for surrogacy to the couple. Then, of course, miscarriages and pregnancy losses are another kind of loss altogether, where bad news needs to be broken. So, at various stages, in various ways, there is the breaking of bad news that happens in the ART process. Now, and breaking bad news would mean that automatically there is grief that is being evoked in the couple, in the patients undergoing the treatment. Disclosing difficult information is a complex process, and professionals, clinicians are often unprepared to manage these communications, which often leads to delay in breaking bad news, or it leads to inappropriate disclosure. Now, that poor communication is reported in the literature, and that also the consequences of the difficulty in that communication or bad communication of such difficult news leads to poor satisfaction among patients, lack of patient care, then lower treatment compliance from the patients, and then reduced quality of care. So therefore, we have to know that when we are breaking bad news, we're intervening in an already vulnerable process. And so having some kind of an understanding of how to be able to break bad news will help us develop a strategy so that we don't have to delay this or get uncomfortable with bad news. Now, since we are talking about grief, let's look at the stages, what grief means, and what are the stages in grief. So grief in ART is often looked at as I mentioned earlier, almost grieving akin to close to death. So the stages are are like this. The first one is denial, which is almost like a shock, surprise, disbelief. The couple feels, even with the diagnosis of infertility, they may feel that, oh no, maybe there is something wrong with the reports, maybe there's nothing wrong at all, everything will be fine, and maybe nothing has gone wrong. So that's the shock, disbelief, denial stage, where the couple is still not believing that anything has actually gone wrong. Then this is followed by anger. Now, these stages are actually not linear. They're just divided into stages, but these stages may occur, any of these phases may occur first for a particular patient, and another one may occur later. So with anger, most clinicians and doctors and the staff find anger the most hard to deal with, because we may often perceive the anger to be upon us. But it's important for clinicians and the staff and counselors to understand that anger is a part of the grief reaction on part of the patient. So this anger may be in the form of, why me? This is really unfair. Why do we have to go through all of this process? And why is it that everybody else is conceiving, but we aren't? This anger may be towards their partner, the anger may be towards the staff, the anger may be towards the doctor, to the medical process in itself, because they place a lot of hope and faith in the process, and then when it fails, they may feel very angry. So on our part, to know that this anger is actually a part of the grieving process helps us keep in perspective that we need to acknowledge the anger of the patients instead of having to be uncomfortable with it. The next stage is called bargaining, which is this can also have feelings of guilt and embarrassment in it. But bargaining is almost like these the patients are saying that they're attempting to do everything right. They're thinking that, oh, did we do anything wrong at any particular stage? They're trying to make all the lifestyle changes possible. They're trying to, if someone has told them you have to be happy and then you'll get pregnant, so they're any moment when they've not felt as happy, or any moment when they've not been how they thought they should ideally be, they're thinking, they're making promises that I promise to keep myself happy all the time so that I can get pregnant. So they're making various attempts in their diets, lifestyles, trying to do everything at their end to make sure that everything becomes right. They may even talk to you about whether, if the medical process would have been done in another way, would have been better. So they're going through all kinds of questioning in their own heads. Then there is sadness. This is the depression, grief, mourning phase of grief, where there can be questions like, I'm never going to have a baby, so what's the point? What's the point at all? So there may be a lot of time spent on crying and mourning and not enjoying any kind of pleasurable activities here in this stage. If this stage is going on for too long, it may be ideal for the couple to seek additional professional help through psychologists or counselors. Then there's a stage of acceptance where the couple feels that it's going to be okay, where they accept that it may take time for them to become a mother or a father, or that they may have to choose different ways, explore third-party reproduction, or even adoption, or explore options of living without children. So that's the stage of acceptance. Having understood the stages of grief, let's look at some of the protocols that could be used to break bad news. Now, there are no specific guidelines yet for managing difficult conversations in ART, but having a strategy may be very helpful in managing the difficult conversation. So the SPIKES protocol by Buckman, which has been used in oncology, has been found to be helpful in the ART context as well. So SPIKES is a 6-stage protocol, SPIKEC, and I'll take you over all the 6 stages quickly. So S stands for setting up, which basically means being prepared for bad news conversations. Bad news conversations will never be comfortable. So making ourselves as clinicians, as counselors, as staff, prepared for bad news conversations, creating a private space, helping the patient sit down first, just setting it up for the conversation to happen. P stands for patient perception. Patient perception is basically understanding the patient's perception of the situation as to what they already know, so that the bad news can be given out or tailored according to the patient's level. So understanding what, if they have any misinformation, so correcting that for them and determining their level of understanding and maybe even their level of denial, so that you can talk about the information accordingly. So taking some time to listen and understand their perception of the situation is important. The next is I is for invitation. Invitation basically means assessing how much information the patient, the couple actually wants to know, and their willingness to hear what is going on before sharing the information. So some patients may actually not want to know too many details. Some may want to know too many details. So determining what is the amount of information that is necessary to share, and first beginning with the bare minimum that is necessary and beginning by focusing on that. The next is knowledge. K is for knowledge. Knowledge is basically, before informing the actual bad news, signal to the patient that bad news is about to be conveyed. And then while sharing information, avoid medical jargon, avoid excessive bluntness. The information needs to be provided in very small chunks and periodically, waiting, checking the patient's understanding, repeating it. So somehow making it a two-way interaction and conversation through waiting and trying to listen where they are. That's K for knowledge. Then there is E for emotions. Emotions is basically responding to all the emotional responses that we just spoke of, the various stages of grief. They could be in shock or disbelief, they could be in anger, angry, they could be sad. So responding to wherever they are in their emotional responses, letting them express their feelings. We can offer support by naming their emotions and normalizing their feelings, telling them that it's normal to feel what they're feeling. Using empathy and empathic responses are very important to acknowledge the patient's emotions as well as the clinician's own emotions. Then the last S is for strategy and summary, which is about summarizing the main points and discussing various treatment options available or follow-up plans. Then the future hope can be built in terms of what can be most meaningful to the patient. It is important to move beyond the delivery of the bad news by giving the couple a new meaning for the ART experience and an opportunity to grow in order to help them accept the situation or consider other possibilities if needed, like adoption or childlessness if at all. So helping them as to what stage, as per whatever stage they are in, so as to what can be the next possibility, and building a follow-up plan with them as a team. That's the Spikes protocol. Just a few things that can be kept in mind when breaking bad news. These are few ways in which one can support in ART. It's very important to be present and to listen to what the patients have to say. We, as clinicians, one doesn't have to have all the answers all the time. Just being there is also extremely important. It's considered one of the most basic rules in communicating bad news that the doctor should not talk too much. It's important to give information and then wait and listen to what the patient is feeling. That becomes very important. Then you can even encourage the patients to put out their own questions, help them, give them an opportunity to reflect and react and ask questions. That is extremely important. Then there is conveying empathy, which is letting them know that you acknowledge that the loss is unseen, but you as doctors, clinicians, counselors, all of us see that this loss is very real, that this can be a very difficult situation and experience for the couple to be in. So to acknowledge that unseen loss, to validate their pain, and to convey empathy, all these come in the same bracket, where they need to hear that their losses, that what they are going through is very real and valid. Then
Sorry to interrupt, Megha.
Yeah.
Please, just we are running short of time. So
Yes, this is the last one. This is the last
Thank
one.
you. Thank you.
Yes. It is important for us as clinicians to become comfortable with breaking bad news. It will never be the most pleasant experience, but we need to develop our own comfort with it. Only then we'll be able to help the patients as well. Let's focus on the person behind the infertility. And sometimes there may be a need for individual counseling because both partners may be having different kinds of reactions to grief. The couple may not be reacting in the same way. So a need for individual counseling may be there. If we focus on these things, bad news and difficult conversations may also help build a stronger relationship and a stronger bond with the patient, which will help, which will enhance our patient care, and it'll make their experience more meaningful. Thank you.
So first of all, let me thank the organizers for giving me this opportunity to chair this wonderful session. Dr. Megha, your presentation was excellent and so discreet. The subject of breaking bad news is a complex and integral part of infertility management. From the couple's point of view, it is not only receiving bad news only once, but it may be repeatedly receiving the bad news during investigation and management of investigation. Already before seeking this medical attention, they have been receiving this bad news every month in the form of unwanted menstruation. So for a couple to exaggerate, there's only one form of good news, and that is of a successful pregnancy. So let's all pray that all infertile couples get this good news in the very initial phase of their infertility management. Thank you. Over to the MOC.
Ji, are you here?
Hello.
Yes,
Dr.
yes.
Shuchi.
So, Dr. Poonam, are you
Yes.
ready with the talk?
Yeah,
Yes.
I'm ready. I'm ready.
Okay, I guess Dr. Shekhar, we have left with the talk with Dr. Poonam. So, Dr. Poonam, please start with your talk with the first talk you have left with. Can you please do the screen sharing, ma'am?
Yes. It's come? Yeah, okay. So we are going to look at the needs of the patient from the time when they first come to the center till they complete their journey, which is almost 4 to 6 years. Now, the entire presentation is based on ASHRAE guidelines, and this is a collection of research collected from world over for last 25 years. So it is all evidence-based. Basically, how do we identify the needs of the patient? Because needs are important. If we don't take care of the needs, somewhere the treatment process starts getting derailed. What are the needs, first of all, and how do we detect them? And how do we address them after that? Now, for purpose of academic discussion, the need is bifurcated into, it is divided into 4 parts, but they are all interrelated, and they actually work in an integrated manner. So there's behavioral needs, relational and social needs, emotional and cognitive needs. And when we talk about stages of treatment, before treatment is the first appointment at clinic, workup, diagnosis of infertility, and waiting period before starting the treatment. Then during treatment, we have all this ovulation induction, retrieval, waiting period before the pregnancy test, receiving results, and the early pregnancy loss and the repeat cycles. Then we have this gray area, which is a heterogeneous group of patients who've been through cycles, who are exploring treatments or thinking of other parenting options or making a pause in the treatment. Then finally, at the end of it, there is either successful pregnancy or an unsuccessful treatment. Now, these are the three basic stages before, during, and after, which I will be taking up. And the patient moves across these cycles, keeping in mind these four different needs. And if the staff can be aware of the most salient needs at every stage, at the beginning, in the middle, and at the end, it will help them to take care better of the patient. So before starting the treatment, very, very interesting. First of all, when the patient comes to you, be sure that only 20% of them are the ones who are clinically significantly disturbed. 80% are those who can be handled by routine care. And for routine care, the infertility team is adequate. For special care, you need a mental health professional. Now, how do we know whether the patient standing in front of me comes in the 80 or the 20% category? We have to know that very early so that we can start. So how do you identify the high risk group? There are standardized psychological tests and there are recognized risk factors which have been identified after years of research. So some of the tools which are available online, they are available free of cost, and they are used internationally, translated in a lot of languages. Screen IVF and Ferticol are fertility specific. And then we have two PGI Health Questionnaire end-to-end ADI, which are also extremely useful for early screening. Now, what are the risk factors that which will help us to will ring an alarm bell in us? When we see a person using passive avoidant coping, rumination, withdrawal, instead of goal directed problem solving approach, thinking rationally about the problem, and so on. So when we see this kind of a coping mechanism, there is trouble. Then another thing is that the woman whose partner has male factor infertility always has very high anxiety as compared with women with other types of infertility problems. And this is not related with depression, but it is related with anxiety. Then presence of pre-existing psychiatric illness is obviously will make a person very vulnerable. And by and large, although women are stronger than men, but through this process, they are more vulnerable.
Hello.
Poonam ma'am, we are not able to hear you.
Maybe she has joined her connection.
Okay.
Yeah. So we can move to the next speaker.
Suchi, please introduce the next. Dr. Anita is there?
Dr. Anita is not there. I would now request Dr. Kavita to please introduce the next speaker, Dr. Yash Shekhar. Dr. Kavita Bhati.
Yeah, good afternoon all. And it is an honor and privilege to introduce and invite our next speaker, Dr. Yash Shekhar. Can I have his introduction slide, please?
Hello, everyone.
Yeah, Dr. Yash Shekhar is a motivational speaker, free driver, grandmaster, Reiki, 15 years experience. And what I got from your PDF file was that you are a healer, public speaker, a good counselor, and have been a yoga instructor and a yoga. So with this, I invite Mr. Yash Shekhar to take this, please.
Hello, everyone. Unmute here now. Yeah. So I will start my, first of all, thank you everyone to giving me an opportunity to be here. My topic is about emotional care, parent and patient care, emotional intelligence and patient care. And I would like to start with a statement about a basic line from our Indian scriptures, which says that Manam Dvisthanam Sukham Evam Dukham, which means mind has only two states. One is of happiness and one is of sadness. So basically, when we talk about the emotional intelligence, am I audible?
Yes, sir.
Go ahead. Yes, please go ahead.
Yeah. So basically, when I talk about emotional intelligence, I have to first talk about the mind. So emotional intelligence in patient care is an application of mind power, based on self-experience and connecting to others' experiences. So mind has basically states. If your expectations are fulfilled, you enter state of happiness. And if your expectations are not fulfilled, you enter a state of sadness. So that's what that ancient scripture said, that manam dvisthanam sukham evam dukham. So the point is how we can use these emotions intelligently to create first self-happiness and then help to spread that emotional happiness using intelligence in the life of the patients. It has an amazing application and use for patient care because patients not only connect to the doctors with a sense of expertise, but also as someone whom they look forward as a big solution provider in their crisis. Because when someone is going through a medical crisis, for them it's also a big emotional crisis and a disaster management situation. So when we go on the topic of emotional intelligence, we understand how the emotions are being taken in the steps. So the first step is about the perception. So at the first step, the entire environment, the entire condition is being perceived by the doctor as well as the patient. So the perception has to be introduced in a way which is positive and at least optimistic for the time being. After perception, the next step is understanding, which is about understanding the situation and trying to comprehend the situation in the best possible way. After comprehension comes the management of the emotions. When I say management of the emotions, so because of the situation's perception and comprehension, there will be a release of emotions in the person's mindset, which has to be managed properly. The result of this management is use and application, which will be in the result of thinking and action. So these are the prime 4 steps or 4 parts of emotional intelligence when applied in reference to patient care. Now, when I particularly go on emotional intelligence in a layman's way, because a lot of the patients who are coming to the doctor, they don't understand all the demos and the terminologies. So the first step is how one can use their own personal experience to create a positive impact in the life of the patient. Now, because a doctor goes through a lot of crisis, a doctor himself or herself is going through a lot of experiential value, how this value can be used to create an optimum position for the patient. This is exactly what's defined as emotional intelligence. The emotions are always there. They're not always positive. There are a lot of them negative also. But how you use them in together with the intellectual aspect to make the best possible result for the patient. An application of all these emotions in the way of thinking, reasoning, and action is what emotional intelligence is all about. Now, when we go to patient care, we have to understand what a patient is going through when this problem happens. The first effect is of stress. Any kind of medical issue when a patient goes through is a result of creating stress. This stress comes out of the pure thought of fear of the unknown. So a patient is not realizing exactly what will be the outcome, what will be the future, and this fear of a failed future results in the creation of stress. To handle this stress, the medical expertise have to understand the concepts of stress management. Now, to understand and work on stress management, we have to understand how the human mind works. There are various tools of stress management. Meditation is one of the best tools, but apart from meditation, mind training is also very well used for this aspect. These tools help a person, help the expertise to choose which of the unique patients needs unique treatment. As every person is unique, as every patient is unique, hence the use of the tool also has to be unique. We can't use the same tool for each and every patient. So as a patient is different, so is the tool. So we have to understand the states of meditation and mind. So I will again use an ancient scripture line which says Chit Vritti Nirodham Iti Yogam, which means cessation of the ripples of the mind is yoga. So whenever there is a ripple, every emotion results in a kind of thinking pattern, which if continued goes to the action state. So if this result is to be controlled, then one has to understand the mind and the no mind state. So first we have to understand what is the mind state and what is the no mind state. Once a person enters a trust factor, a trust field, a person is in no mind state. So suppose a patient comes to a new medical environment, he or she is seeing all the medical systems and the doctors with them. So there's 100 questions which comes up in the mind of the patient. The fear of the unknown is there. The fear of the outcome is there. How the treatment will go will be there. So all these are mind conditions. They're all ripples of thoughts in his or her mind. And every extra ripple results in stress in a person's mind. The more the stress, the less the relaxed state of mind, and hence less will be the effect of the healing procedure. So we have to help a patient reach from a mind state to no mind state using tools of emotional intelligence, which are stress management. So first of all, we have to understand where is the biggest limitation of the mind. The biggest limitation of the mind is human mind cannot understand and work on the word no. The independent word no by itself has no meaning for the mind. So let me prove it with an example. Suppose I use the word happy. It creates a sense of happiness. If you imagine something happy, you create a sense of happiness. And if I use the word sad, it creates a sense of sadness. There are two extreme emotions in a human mind. Now let me replace the word sad with the word not happy. Now the meaning, literal meaning remains the same, but the application meaning in the mind at the emotional intelligence level changes. So when I use the word not happy, the human mind first has to go to the word happy and then add a no, resulting in not happy. But the reference becomes the word happy. So if I use the word not happy instead of the word sad, I have diluted the sadness index in a person's mind. Same if I replace the word anger with not peaceful. So the intensity of the emotions can be changed very easily by the selection of the words. Scientifically, what I'm doing is that I'm replacing every negative word with a non-positive word. So this is the tool, one of the biggest tools of stress management which we are using in mind training, where we replace every negative word with a non-positive word. And if we are not careful, if someone is not trained properly, if the empathy level is low, they can do the reverse, where they replace every positive word with a non-negative word. So instead of using the word good, if you use the word not bad, it creates a negative effect on the mind. So we try to use either positive words or non-positive words and we try to avoid negative words and non-negative words, because human brain and human mind cannot independently work on the word no. It needs a reference to work with no. And hence we try to focus on positive and non-positive words. The second postulate of meditation and mind inputs is real or virtual. Now, human mind is taking data from the environment every second, not only from the level of the mind or emotional interaction, but also through all the five senses. And it's a huge amount of data it is processing. However, apart from the real world, it also takes immense data from the virtual world. So human mind cannot differentiate between the real or the virtual world. I'll give another example. You see people watching a movie and they feel sad, happy, angry, euphoric. So basically the movie, though it is an artificial thing, though the actors are just playing a role for 1.5 to 3 hours, still it creates a really real impact on the person's mind, because human mind cannot differentiate between real and virtual. The more the number of senses are involved, the more a person's mind and emotional state gets involved. Now, this is very important for understanding stress management. If a doctor is understanding the patient's emotional state and using proper words and body language interaction, it creates an immense difference in the level of absorption of the positive energy. So for that, one has to understand that mind, be it real or virtual, always takes everything as real. So
Sorry, Dr. Yash, to interrupt. Just please, we are running short of time. If you can wind up early, within 2 minutes. Yes.
So basically for real and virtual, we have to understand both are the same for the human mind. Now, the third postulate is about looping. Looping is basically the ability to use the words in such a way that it creates a stronger impact. Generally, we use it in the software industry, where you use the loops for creating the same iteration going again and again. So basically, if you use the words in a similar fashion and create a looping effect, it creates a more powerful impact on the human mind. So mind has layers now: conscious, critical, and subconscious. Conscious mind is at the surface. It takes the feedback from all the five senses. Critical mind is in between the conscious and the subconscious and is the main decision maker or judgmental factor in our interaction. All the experience of the mind result in creating of the critical mind. So when a child is born, there is no critical layer. It gradually develops in the mind as the interactions develop up. By the age of 20 years, this mind layer is fully developed. And any information, once it reaches the subconscious mind, is fully accepted by the patient. So once a doctor is able to reach the subconscious mind of the patient cooperates the maximum to the doctor. Hence, we have to understand that how we can bypass the critical mind by proper body language and use of words with the patient. Mind has again states of depth. I've used the word beta, alpha, theta, delta. Beta is the most superficial. We normally are in the beta states when we're interacting with someone. Then is the alpha state. This is the state just before you enter sleep and just after you wake up. During this state, you're in a state of sleepy wakefulness. It's the most relaxed state from a normal functioning of a person. And as we talk well, as we interact well, a person gradually enters into alpha state. Good music, good level of meditation, breath watching helps to enter beta state to alpha state, followed by theta and delta states, which are even more deeper. We can use breath and meditation work to enter these states. The worst kind of breathing is the short and fast, which is under stress. The purpose of stress management is to take the breath from short and fast to deep and fast and gradually to deep and slow. So the success of stress management has the biggest indicator in form of breath. As your breath gets deeper and slower, the successful is your model of stress management being used. So thank you, everyone. I have tried to summarize everything in this platform. And if you have any questions, do reach to me. Thanks.
Thank you so much for a very enlightening and a very interesting talk, Mr. Yashekar. And very well, you have brought out and explained the importance of emotional intelligence in healthcare and how to manage stress, the play of words, negative and positive words, which needs to be incorporated in our day-to-day practice while we are dealing with patients of infertility and ART. The importance of body language also and the mind states. Thank you very much.
Thank you.
Are you ready? Poonam ma'am, please unmute yourself. Unmute yourself.
I'm unmuted.
Poonam ma'am, yes.
Okay. So we were talking about the stage when the patient enters the clinic. The main dominant need is cognitive, to understand what is happening. And in this process, uh, this if this is handled properly, then a lot of stress, a lot of uncertainty in his mind is not there. Now, what happens? You are medical people, and the patient is probably from arts background or some other background. He listens to the consultants and the team of doctors sitting there, spellbound and quiet, comes out of the consultation room and starts asking the receptionist, the nurses, and all the ancillary staff for clarification, which they cannot give. So the thing is that since it is such an important need of the patient, it it should be addressed by the team, by the infertility team, and there is a process that you explain to the patient all the processes of care, and then ask him to summarize back whatever he has understood. That is, take a feedback to check if he has really understood, so that this communication breakdown, which has very serious repercussions that's later on stages, that should not happen. So it is my feeling that there should be one or two people who are allocated the duty of making sure that the information is given properly to the patient, and it is checked also that it is taken up. Because this has been identified by Ashri as one of the most important needs in infertility treatment, and this remains important at every step during treatment, when they are changing tracks and when they are ending treatment. So that communication pathways have to open. अब ये slide नहीं हिल रही. Teddy? I don't know. My slide is. So what are the emotional needs before the first line of our treatment? This was the cognitive needs. Now we are talking about the emotional needs. Are they depressed when they come into the clinic? 25 years of research, they are absolutely not depressed. The level of depression is the same as in a general population. Are they anxious? There is a controversial evidence. There are some studies which say they are anxious, some others say. So might be patients with cultures with strong pro-natalist view that they start having more emotional baggage about having a child. Then what are the relational and social needs before starting the our treatment? They have normal marital adjustment, normal physical relations, and there is no indications which sets them apart from the normal population. And what are the risk factors for increased relational stress during ART is this divergent views of partners. When you see that they are, sometimes we do see a couple where one partner is quite indifferent and the other is very eager to have a baby and so on. So this is something which needs to be kept in mind. This later on leads to further stress. Then here, another very important thing is to involve both partners in diagnosis and treatment process right from the beginning and manage them as a team by improving communication between them. There are patients who come and give a test tube sample and go away. That is really not a valid practice. Now, in our context, there is not only the couple, but there's a huge family also there. So the couple has to decide, there has to be a consensus on how much information will be confidential and how much will be shared by whom and by what. Then another important aspect of is to provide social support groups, give them information, allow them to connect with other patients who are coming for treatment so that they are comfortable, they are validated, and they feel they are on a shared journey with others. What are the behavioral needs before art? That is, lifestyle behaviors which negatively affect the general and reproductive health. One has to look into that, and it is important to address them also, because by education, by increasing the awareness about it, and support patients in weight loss programs. And here you can integrate yoga for improved physical and mental health. Preconception care is a very, very important facet of beginning phases of treatment, where even small interventions, they increase the chance of treatment success, and yoga also improves outcome here. We can give it in groups. It's an economical and effective means associated with improved IVF success. We have got data from 2 studies, one from Maulana Azad Medical College. Dr. Sudha Prasad was the lead here. And then second at our center, where both the studies showed us that the yoga actually really gave a significant contribution in physical, mental well-being, as well as infertility outcome. So this is the time where the yoga can move out of all these areas, from ashrams, from gyms, studios, and come into the mainstream to transform the society. Now, so in summary, before treatment, there are 2 salient needs. One is the lifestyle management, and second is the need for information. Emotional and social needs are not salient. But during treatment, everything starts turning around. There is confusion, there is chaos, and there's a huge amount of stress. There is an obsession about, will this be successful or not? Will this work or not? And we met cases where it's like it's a 24/7, where they are thinking about this and nothing else. And during this process, they are just wondering what will happen. If this doesn't happen, then what will happen, and so on and so forth. And in this process, there is a kind of distorted thinking where they downplay the facts, information about pregnancy rates. They become more optimistic, and here they have a kind of illusion that I will be lucky anyway. The statistics don't really matter. I'm the lucky one. So their expectations may be more realistic, but the reality is that nobody knows what is going to happen.
Sorry to intervene, ma'am. I'd like you to wind up the.
Okay. So this is that during the emotional needs are increased, and here there is a lot of depression, anxiety, and relational strain. And there are 3 periods which have been very well identified by research, which are very high stress. And these are the periods of waiting period and invasive procedures. And the studies have shown that no complex psychotherapies work here. We need a psychoeducational protocol, a skill training, which can be done in groups, and which can be, which the patient can learn and continue to practice at home, because during waiting period, they are at home. They are not coming to the clinic. They don't need any medical checkups, and they don't have support of other people around them like they have at the clinic. So for them, it is extra important now that at the pre-treatment phase, they learn these techniques, they learn them well, so that when they go home, they can start employing them to themselves. There is this positive reappraisal strategies, which is learning to think in a positive manner. And these are pocket-sized cards. This is validated and tested in other disease conditions also, where there's uncertainty and doubt about the outcome. And you have statements like this. The patient can take it out 2-3 times a day and keep reading it. and it is like a dose of positive thinking coming in his way or their way. So needs, this is during treatment, it is the emotional turmoil and the need to have some good skill in place, which probably should have been done right at the beginning, so that it carries through during treatment, where the patient can continue to on their own at home also. After unsuccessful treatment, this picture tells the whole story. Dr. Megha has said also quite a lot about it. And here is the biggest risk, where there is a need, what she has already said, there is a need to set a protocol. And long-term studies have shown that those who get the child, who accept that they cannot have a biological baby, but they are able to get on in life. But the biggest problem is the unsuccessful treatment with a persistent desire for a child. This is where the data is quite horrible. And this is where the psychiatric disorder in general population is 3.5. And in these people, it's come to 20% and 25%. It's a very, very high rate. From 3.5 to jump to 25, it is sad. Then these are the people.
Just a reminder for the time, ma'am. Just a reminder for the time.
This is the conclusion, and thank you so much. Thank you.
Thank you so much to all the speakers and the chairpersons for hosting this wonderful session. I'd like to now invite the chairpersons for the second session. Dr. Rakhi Malhotra, Director, Ask Fertility and Maternal Center, Rohtak, Haryana. Dr. Madanjeet Parishcha, Director, Parishcha Hospital and Maternity Home, Gurgaon, a very senior consultant in the field of infertility. Dr. Gulpreet Bedi, a senior consultant, obstetrics and gynecology with special interest in infertility, founder, president, Isar Chandigarh. Dr. Anju Yadav, with a fellowship in reproductive medicine, a senior consultant at Cloud9 Hospital, Gurgaon. Special interests in RIF and POR. I'd like to now invite Dr. Rakhi Malhotra to please call upon Madam Joanne Coverdine, our esteemed international speaker.
Thank you, organizers, for inviting me as a chairperson. Am I audible? Hello?
Yes, you're audible.
Yes, ma'am.
Okay. Good afternoon, everybody. May I have an honor to invite Joanne Coverdine. She's a joint founder and CEO of the National Fertility Society. And she's a senior specialist fertility psychotherapist. And she has a 20 years private practice. She's also joint owner of not-for-profit Unique Women's Health Clinic. And she's a lifetime member of many organizations, IFS, ASHAR, and many others. So please, may I have a speaker, Joanne?
Hello, everybody. Can you hear me okay?
Yes, Joy, we can hear you.
Wonderful,
welcome.
Thank you. Thank you very much. Okay, bear with me because the laptop has decided to bring up an alert. Hello, everybody. I'm Joanne Coverdine. I hope you're all well and managing in these really difficult times. I will do my best to find my PowerPoint presentation, which has also disappeared off the screen. But until Sandra comes back through the door and helps me with her very complicated Apple Mac laptop, I will start. The reason I wanted to talk about the psychological effects of PCOS is because it's something that's becoming far more apparent in practice and also within the women's clinic that we run here. And obviously we all know that the statistics are rising exponentially, actually. So I wanted to start by saying how we manage this here in the UK, and hopefully that will be of help to you out there in India. I'm not going to go into the medical side of it, obviously. I'm just going to stay on the psychological side. So as we know, we have many things that happen with PCOS, and people can present very obviously with PCOS or with minimal signs. So we have things like extra hair growth on their face and their body, or they can also have thinning of their hair on their head. They can have sleep issues. They can have irregular or missed periods, infertility issues, obviously, mood swings, acne, weight issues, ovarian cysts, insulin resistance, and high testosterone levels with a low sex drive. All of these things can impact on people's mental health in a big way. If you take any one of those things, then it can become a serious issue for you. If you have facial hair growth, then it's very stressful. And especially when you're dark haired, and it becomes very, very obvious. And so what I like to do is when I'm counseling people with PCOS, I want to work on the person as a whole. I want them to be able to come to me and not only focus on the psychological aspect of it, but I will work really quite psychodynamically, where I'm drilling down into their upbringing, their conditioning, their past behaviors that perhaps have created some bad habits around their eating, their diet.
Sorry to interrupt, Joan. Your slides are not visible. If you can please share the screen.
Sorry, you broke up. I couldn't hear you then.
Your slides are not proper. My presentation is not visible to us. So could you please share your screen for your presentation?
Okay, bear with me then.
Could you please share your screen for your presentation?
Yes, I'm trying.
Okay,
Bear with me
bear
2
with me
seconds. Sandra, I need your help. Okay, I've tried to share the screen and it's brought this up. Yeah. My IT expert, Dr. Sandra.
Great.
I'm for patients. Okay, that's it. Cool. Okay. Can you see them now? I've tried to share the screen and it's brought this up. My IT expert, Dr.
Great.
Patients. Okay, that's it. Cool. Okay. Can you see them now? I've tried to share the screen and it's brought this up. Do you have them?
It's visible but not completely visible. You make it please maximize mode. We can see only the upper headline only, dear. It's visible but not completely visible. You make it. Yes, it's okay now.
Now we can see. Now we can see.
How do I go?
We can see only the upper headline only.
Yeah, okay. Okay, so, and this is a picture that I would see very commonly in the UK, this photograph that I've put on here. And this is why I would like to work psychodynamically.
Yes, it's okay now.
We can see. Now we can see.
How do I go?
We can see only the upper headline.
Okay, so this is why I have a terrible echo as well. Can you hear me clearly? Photograph that I've put on here. And this is why I would like to work psychodynamically.
Dr. John.
Subir, can you please check the technical error? Yes.
Yeah, Dr. John, have you joined with 2 devices?
Okay, so this is why I have a terrible echo as well. In the photograph that I've put on here.
Maybe Dr. Priya, she has joined with 2 devices. That's why. Now her hand. Dr. John, have you joined with 2 devices?
Joan, have you joined with 2 devices?
Please unmute yourself.
Joan, please unmute yourself. Yes, and just please log in with a single device only.
Ma'am, we are unable to hear you.
Joan, please unmute yourself.
Tell her to unmute now because her friend understands it.
I know. Sandra, please unmute. Unmute, yes. Yes.
Okay. I'm unmuted.
Perfect. Yes,
Now.
yes.
Okay, right, bear with me a second. So as I say, this photograph epitomizes what goes on in the UK, and this is why I want to always talk to them about
Sorry to interrupt.
Sandra, please unmute. Unmute, yes. Yes.
their diet, their
Hello?
lifestyle,
Dr. John.
their exercise.
Perfect. Yes, yes.
Okay, right, bear with and me obviously a second. So we as know, I say, this
Dr. John. Sorry to interrupt you, ma'am. You have joined with 2 devices. There is some echo, right?
I think a friend has joined with 2 devices, so there is some issue, CL black end. So I think that they need to be told, and she has muted herself.
Yes, ma'am.
Sandra, the issue is that she has joined with 2 devices. So that's why the voice is having echoes.
no,
You have to join with a single device, Joan and Sandra.
So there's some issue, CL black end.
No,
So
we've
I think
only,
that they
we've only
need
got
to
the
be
one
told, and
device.
she has muted herself.
Yes, ma'am.
No, we've only got the one device.
Have you joined in from the front
The
end?
issue is that she has joined with 2 devices. So that's why the voice is having echoes.
Drink the tea.
No, you have to join with a single device, Joan and Sandra.
So there's some issue, CL black end.
No,
So I think that they need to be told, and she has muted herself.
Yes, ma'am.
So is that no, we've only got the one device.
Have you joined in from the front
The
end?
issue is that she has joined with 2 devices. So can you hear us, John? Please unmute yourself, John. Yes, so now can you hear us?
Yes, can you hear us?
Yes, now it's perfect. Okay. So you have to hear us, John? Single device.
Is that working now?
Perfect.
Oh, perfect. There you go. Then. Okay, so I'm not sure whether you heard where I got to, but as I was saying, I wanted to talk to them psychodynamically so that I can have their
single device.
Talk about their diet and exercise, because obviously what we want to do is if we can catch these girls early enough, we can try and prevent the problems. I'm not sure whether you heard where I got to, but as I was saying, I wanted to talk to them psychodynamically so that I can talk about their diet and exercise, because obviously what we want to do is if we can catch these girls early enough, we can try and prevent the problems. I'm not sure whether you heard where I got to, but as I was saying, I wanted to talk to them psychodynamically so that I can talk about their diet.
Okay. Suchi, can you please take over? I guess there is some technical error and she's trying to correct it. Suchi, are you there? Yes.
Yes. So due to some technical error, Madam Joan is not able to join us immediately. So I'd like the chairpersons to uh, discuss PCOS. And let me just get back to the technical team and make sure that it can function a little
Yes, I
more
guess now
smoothly.
till the time that Jones is not there, can we start the session 3? Do we have the speaker Mirambika?
For session 3,
Are you there?
Yeah, ma'am, she is there.
So Dr. Ritu, can you please introduce Mirambika for the next session till the time Jones is not preparing for her technical correction?
Sure, I will.
Mirambika, are you there? Please switch on your video.
Yeah, I'm there. I'm trying to
Professor
share the.
Mirambika ready with her presentation? Can I introduce her? Hello?
Yeah, but then.
Is Professor Mirambika ready with her presentation? May I introduce her?
Yes, ma'am.
Yeah, I'm not able to share the presentation.
That ma'am will help you.
Help
You
her,
just go to share screen. Yes, just go to share screen and you can open your presentation, ma'am, directly from there.
Yeah, I'm going there, but.
Dr. Mirambika, your internet connection is not still.
Yeah, let me just.
First of all, I must congratulate Team Fertivision 2020 for organizing such a workshop for this. That too virtually in such a manner. It is so difficult to organize the things. And despite the best efforts, sometimes some technical glitches are there. So here we go ahead with Professor Mirambika Mahapatro's presentation. She is going to speak on a very different subject, social construction of infertility and changing gender relations.
Yeah,
So,
it is not accepting, that is what. So make me either host or co-host, or I have already shared my presentation. If you can do it from your side.
Please someone help Professor Mirambika to share her screen, or somebody else should say, share her screen instead.
Shivam, can you help?
Dr. Mirambika, you just to click share screen.
Yeah, I did that.
Yeah. So you open your PPT?
No, it is not actually accepting it. I have opened it, my PPT.
There's a small share button, ma'am. There's a small share button at the right hand corner of the screen. You have to press that also.
Green button.
There's a share button. After you select the presentation, you're supposed to select the button share.
Share screen.
Yes. After share screen, you select the presentation. And after selecting the presentation, there's another toolbar at the right end which
But
says
then
share.
it is not accepting the way you are saying. See, it is not accepting. So I have already shared my presentation with a group.
So Priya, you, Dr.
You
Priya.
have the presentation. Suchi, you have the presentation of Mirambika.
Ma'am, Dr. Priya must be has it, I think, and I'll just tell her to switch it on.
Okay, I'll just do it. Rima, are you ready with the presentation? Can we start with you next? If you are ready with the presentation, till then I'll do the things out.
Yeah, just let me open my presentation. Yeah,
Okay.
I'm ready.
So Chairperson, please introduce Rima Dada for the next presentation.
Can you see my slides?
Yeah, sure. We have seen.
Okay.
Suchi, can you please put an introductory slide for Reema Dada?
Ma'am, the MOC is Neeti, but I'll still go ahead and ask the chair people to introduce from the slide, the introduction slide that ma'am has already put on the screen.
Yeah, I'll just go ahead with it. Everyone knows Professor Reema Dada. She has been part of Fertivision in yesteryears also. She is going to speak on a very, very important topic, the need to integrate yoga into infertility treatment. And we all understand that everything works from brain and heart. And next is the carry on commands only. So same way, integration of yoga into infertility has been very beneficial, although there are not much scientific evidence to it, but whatever evidence we have. So here we have Professor Reema Dada to speak on the subject. Madam, please, Dr. Reema Dada.
Thank you, ma'am. And I would just like to tell you that I will give you the scientific evidence that why it's how yoga is so important in infertility treatment. And we've been working on the impact of yoga for the last 8 years on the impact on the sperm genome and epigenome. So my topic is the need to integrate yoga into the infertility treatment. And as we all know, it's the inability to conceive after 1 year of regular unprotected intercourse. And I would basically be focusing on male factor infertility because that's what I've been working on. And though it's equally effective in female infertility too, and I will give you the scientific data. What's important to know is that there are 1 in 20 men do experience infertility. And when they come to us, first thing that we do is a semen analysis, but we also know that sperm parameters, the conventional sperm parameters are very poor predictors of fertility potential. And in cases with azoospermia and oligospermia, usually we do a cytogenetic analysis and we do get cases like Klinefelter syndrome or these XYY or cases with YQ microdeletions. And these are indicative of severe testiculopathy. But then there are a group of men who have normal sperm parameters as per WHO guidelines. And it is this group of men that we are interested in, these men with unexplained infertility who are still infertile. Now, in this group of men, when we look at them and do other tests, for example, we do the oxidative stress as well as study the sperm DNA damage, we find that a large percentage of these men have seminal oxidative stress as well as, and we try to correlate them with their lifestyle factors. So they do have oxidative stress. And then to understand the cause for oxidative stress, because the free radicals are produced by the mitochondria as byproducts of ATP production. So we find that these are the cases which have high number of mitochondrial variations as compared to the control population. Therefore, they have both neat and high washed free radical levels and a lower total antioxidant capacity and a higher DNA fragmentation index. Why I'm just showing you this is because I'll show you how yoga is helpful in each of these cases and how it circumvents all these problems. So we also quantify the level of DNA damage either by comet assay or by sperm chromatin structure assay. And we can see that in the infertile cases, these are sperm. When you do this comet assay, you can see they have longer tails showing the level amount of fragmented DNA versus those cases in the controls. We also study the level of DNA damage by sperm chromatin structure assay using flow cytometry and using actinium orange dye. So we have been able to establish the level of DNA fragmentation index. The level which is beyond 8 to 21 is normal, and beyond 30, the couple is unable to conceive spontaneously. Now, the most important thing is when they have high levels of DNA damage, it's very, very important that you actually assess what is the cause of DNA damage. And the most common cause of DNA damage is oxidative stress. And it results in the production of this oxidative DNA adduct. Now, this oxidative DNA adduct is both mutagenic as well as it causes epimutations. And when we quantify the level of this mutagenic adduct, we find that in fathers of children who had retinoblastoma, these are sporadic cases, these are not heritable cases. So this is just an example. When they have high levels of DNA damage, they have high levels of oxidative DNA damage, which affects the next generation. So what I just wanted to tell you that this is an oxidative DNA adduct, and this oxidative DNA adduct results in de novo germline mutations in the sperm DNA. And because the sperm has a highly truncated repair mechanism, because it is both transcriptionally and translationally inert, it transmits this DNA damage at the time of fertilization, and the oocyte tries to repair the DNA damage. But if the DNA damage is very high, it passes on and it goes into each cell of the zygote then during cleavage is passed to each cell of the embryo. And we find that this is the cause of most of the post-zygotic mutations and is responsible for a higher incidence of both genetic and epigenetic disorders in the offspring. Also, optimal levels of oxidative stress are required for maintaining optimal telomere length, which is very, very important for having a healthy, for having optimal cleavage and the optimal cleavage rate. So it has been seen that very low or very high levels of free radicals results in shorter telomeres. So what I wanted to just emphasize still now is that oxidative stress is one of the main causes of unexplained male infertility, and it happens by a number of factors, majority of which are modifiable. And also, as we are delaying the age of marriage, we are increasing the level of mitochondrial mutation, which actually results in higher levels of DNA, oxidative DNA damage. So what most people do is they go in for the doctors mostly give them antioxidants, but what our studies have shown, these are double-blind, randomized controlled, placebo-controlled trials, that though they improve the concentration and the motility, very few antioxidants at the therapeutic levels have any effect on the DNA fragmentation index. So the WHO recommends, and the Physicians Committee for Responsible Medicine to circumvent oxidative stress says that we need to have 5 to 10 servings of fruits and vegetables. Now I'm just shifting just to show you that when you have high levels of DNA damage, the fathers have high levels of mutations in the sperm DNA, and that is responsible for sporadic retinoblastoma in the children. Now, what we've studied, this is just to show you higher levels of free radicals and a higher level of DNA damage, and you can see that their children have higher incidence of mutations, and this is mainly seen with people who are nicotine consumers, alcohol users, and also when they have delayed a higher age of marriage. Usually it's seen that these are children with the last born child when the level of DNA damage, oxidative DNA damage is higher. So now what we did is that in these men who had high levels of DNA damage, they underwent yoga intervention, and we assessed the conventional semen parameters, their oxidative stress, DNA damage, total antioxidant capacity. We studied the level of this oxidative DNA adduct, which causes both mutations as well as epimutations. So we studied the sperm genome as well as studied the sperm epigenome, because at the time of fertilization, the sperm is not only transmitting a DNA, but is also transmitting the RNA. And so the optimal level of these sperm transcripts are required for the birth of a healthy baby. So what I wanted to show you here, that you can see that there is an improvement as the free radical levels decline with practice of yoga. There is an increase in the progressive motility also. Also along with that, because of decline in free radicals, you can also see that there is a significant decline in the levels of the DNA fragmentation index. We also quantified the level of the total antioxidant capacity. Now, 10 servings of fruits and vegetables in our country, I think very few can afford. So you can see that yoga on its own causes a significant increase in the levels of total antioxidant capacity, whereas the group that did not practice did not show any change in the total antioxidant capacity. We also find that the telomerase level increases, which helps to maintain the telomere length, whereas a group that did not practice did not show any change in the telomere length. Now, sirtuins are anti-aging genes. These are histone deacetylases, and these are the genes which actually show increased expression when you have red wine. And there was a rage when it showed that when you have red wine, it increases resveratrol and it causes increase in sirtuins. Our study was the first to show that independent of intake of red wine, sirtuin levels increase if you actually practice yoga. In addition to that, we studied the transcriptome, and we find that you can just see here that a large number of genes, which are the transcripts which are being transmitted to the offspring, you can see in the control values, and you can see in blue that the levels are highly different from the controls, and you can see with practice of yoga in red, the levels are coming down to getting normalized. So with practice of yoga, you not only are improving the DNA integrity, but also normalizing the level of sperm transcripts, which are very, very important for early embryonic development. In addition to that, we also studied the sperm epigenome, and we find that you can see that in the yoga group, we find that with oxidative stress, there is global hypomethylation, which makes the genome unstable. And our studies have shown that methyl cytosine levels increase because there's a decline in the oxidative stress, and there's a decrease in the level of hydroxymethyl cytosine, which is the base which is accumulating when there is oxidative stress. In
Ma'am,
addition
can
to
you
that,
please maximize your slides? They are still in the minimize mode.
no, I can see them as maximized. Just 1 minute.
Okay, not an issue. Yes, this is
Okay,
fine.
okay.
Great, great.
Right, and so we also did this study where we studied the sperm methylome, and what I wanted to show, when you have hypomethylation of genes, they are expressed, and the genes which are hypermethylated, they are silenced. And we find that those genes which help to maintain the spermatogenesis, which are helping in promotion of fertility, maintaining sperm DNA integrity, they were hypomethylated. So yoga is impacting not only the DNA, but also the epigenome. So the genome and the epigenome. And we published a study to show you that when you can see here that when you practice yoga over a period of time, now here each dot represents a sperm, and the number of dots towards the x-axis are the ones with the damaged DNA, and towards the y-axis are the ones with the intact DNA. And you can see that with practice of yoga over 6 months, you can see that there's been a significant decline in the DNA fragmentation index. So that's very, very important, that just by practice of yoga, there has been a significant decline in the levels of not only free radicals, but also a decline in the oxidative DNA damage, a decrease in the levels of oxidative DNA adducts, as well as an improvement in the sperm DNA integrity. So you can see that there's a decline in the free radical levels, an increase in the total antioxidant capacity, and a significant decrease in the levels of the mutagenic adduct, that is 8-hydroxy-2-deoxyguanosine. And to understand why this happens, we studied the mitochondrial integrity, because a decrease in the damaged mitochondria are the source of free radicals. And we see that with practice of yoga, you find that this is just a recent study we completed. So we've sent this paper for publication, but it was accepted in ESHRE for presentation. And you can see that there's a significant improvement in the mitochondrial membrane potential. Also, we see that the expression of genes which are maintaining mitochondrial integrity, they show an upregulation. So they help to maintain the mitochondrial integrity. This base is also showing an upregulation, and the mitochondrial copy number increases, which shows it's a compensatory mechanism. Also, as we just saw that, especially in counseling, we heard in the previous lectures that these cases have depression, they are highly anxious. And as Dr. Poonam Nair told us, that there are about 20% cases which do have high levels of stress and depression. So you can see that yoga is not only improving your reproductive health, but is also improving your levels of stress levels, and that is your depression. And we find this occurs because there is an increase in the level of various factors which promote neuroplasticity. So not only is there an improvement at the functional level, but also we see structural changes because there is increase in the levels of various factors like brain-derived neurotrophic factor, serotonin. A decline in the level of serotonin is responsible for depression, and we see with practice of yoga, there's an increase in the serotonin levels. Because they are disturbed and they are so highly depressed, there's a decrease, there's an altered sleep-wake cycle, which also gets regulated because of the increase in the levels of melatonin. And also it's important that this is one of the most potent antioxidants which is found in the mitochondria, which helps to maintain which also helps in aiding in maintenance of mitochondrial integrity. And again, in depression, we find these people with psychological stress and depression, they have high oxidative stress, which shows a decline. Again, an increase in total antioxidant capacity, and it's been seen people with depression, they age much faster. So you can slow the rate of aging also by doing yoga. In addition to that, we've seen there were a number of cases which also had autoimmune diseases like rheumatoid arthritis, and we found that even those cases which practiced yoga, even in these cases, there was a significant improvement. Not only was their joints more flexible, there was a decrease in the pain scale, that is the visual analog scale. And in addition to that, a large number of genes, which are actually anti-inflammatory genes, and the genes which are causing inflammation, anti-inflammatory genes expression goes up, and the gene which cause inflammation like IL-6 and IL-17, which are responsible for both the articular and the extra-articular symptoms, show a decreased expression. So not only in male infertility, though I'm not working on female infertility, we've just studied in some cases the levels of leukemia inhibitory factor. What I wanted to show you that not only in male factor infertility, there are several studies, though these are not ours, which have shown that they improve in cases of polycystic ovaries and metabolic syndrome. And there's a better carry home live birth rate in cases which practice yoga, especially in couples with infertility. And our study has shown that in cases which are going in for assisted conception, when they do practice yoga, the women have shown an increase in the levels of leukemia inhibitory factor, which helps in better implantation rates. So I would just like to sum up by telling you that a host of lifestyle and environmental factors actually causes oxidative stress, which is responsible for both mitochondrial and nuclear DNA damage, telomere shortening, which is responsible for genomic instability, and it also is responsible for epigenetic changes. And when you practice yoga, you decrease the oxidative stress levels, which decreases the level of mitochondrial and the nuclear DNA damage, helps to maintain the telomere length, decreases the base, which causes both genomic and epigenomic changes, and there's a decline in the free radical levels. So on the whole, I would just like to sum up by telling you that yoga is not only important for improving the DNA integrity, the genomic DNA, but also the mitochondrial genome shows an improvement in DNA integrity. There's also changes which positively impacts the epigenome. It impacts the cellular as well as the mind-body communication markers show an improvement. There's improved neuroplasticity, and thus this not only affects the individual, resulting in a better reproductive health and increasing the carry-home live birth rate, and it will help to counsel the patient, improve their emotional resilience. But it is also very important because it also impacts the lifelong health trajectory of the offspring. Thank you.
Thank you, Dr. Reema Dada. You really showed us the evidence which is coming up. So it was a very nice presentation indeed.
She's talking.
Thank you, ma'am.
Yeah. So to conclude, excellent talk. Thank you so much, Dr. Reema, for giving such an excellent talk on. I'm giving that your conclusion that both in female and male infertility, there are scientific data and there are evidence-based papers and work which is being done. And in female, there are the data show which with 12 weeks yoga, the hormone level of LH, testosterone, reduced. This is one point. The second point is cortisol level is reduced. And because of that, the anovulation, some of these patients with anovulation, they become ovulated, they have a ovulatory cycle, and it helps in patients with the anovulation and PCO. In men, very important talk you gave, there are scientific data which shows the DNA integrity being maintained, and oxidative stress and free radical is less, and it helps both in mitochondrial damage and also DNA damage. And another very important thing you said is sexual dysfunction also, which is there are some papers which shows because reduction in serotonin and sometimes the endorphin, it helps in these men, they can resume their functional capacity in the form of their sexual life. And these are the evidence based. I think there are a lot of papers being published, and now it is role of yoga is becoming very important for both infertile men and also women. And
yes, ma'am, we've also found increase in nitric oxide levels, which helps also in erectile dysfunction.
Yes, it is being proven now. I think more study need to be done in multi-center study.
Right.
Thank you.
Thank you, ma'am.
Good afternoon, everyone. So since due to the technical errors, we have started session 3 directly. So I was not able to introduce the chairpersons. So please may I have the proud privilege to introduce the esteemed chairpersons. Dr. Roya Rosati, ma'am. Ma'am is Professor, Head in Department of Obstetrics and Gynecology, Shadan Institute of Medical Sciences, Medical and Research Director, MHRD Hospital and Research Center, Banjara Hills, Hyderabad. Special field of interest, infertility and endometriosis. Next, we have Dr. Ritu Jain, ma'am. You're welcome, ma'am. Dr. Ritu Jain, ma'am. Ma'am is Director, Vadman Medicare IVF and ICSI Center. Ma'am has special interest in infertility and laparoscopy. She has been in private practice for the last 26 years. Ma'am has contributed a lot of chapters in so many books we read. We welcome you, ma'am. We have Dr. Mala Srivastav, ma'am. She's Senior Consultant and Professor Gripmer. She's a gynae endoscopic and robotic surgeon, Sir Gangaram Hospital, New Delhi. Ma'am has special interest in gynae oncology, endoscopic surgeries, and robotic surgeries. And ma'am is President AOGD 2020 to 2021. We welcome you, ma'am. Next chairperson is Dr. Pramila Malik, ma'am. She is immediate past President, Gurgaon Obs and Gynae Society, Director of Chiranjeev Hospital, New Colony, Gurgaon, has a special field of interest in infertility and high-risk pregnancy. Dr. Ratanmoli Bhattacharya, ma'am. She's Senior Consultant IVF Center at IVF Akansha IVF Center and Mata Chanan Devi Hospital. Senior Consultant, Department of Infertility and IVF, JP Hospital, Noida. And ma'am has received a lot of awards for original research work at national level conferences. We welcome you, ma'am. Welcome all the chairpersons. Please introduce the next speaker, Dr. Mirambika Mahapatru, ma'am. Ritujan, ma'am, you have to introduce Dr. Mirambika, ma'am. Please introduce.
So I hope someone is sharing madam's slide.
Ma'am, can
Professor
anyone?
Mirambika is speaking on a very different subject, that is social construction of infertility and changing gender relations. Professor Mirambika, madam is professor at National Institute of Health and Family Welfare, New Delhi. And so we have madam, please. Professor Mirambika, please.
Ma'am, can you see the slides? Everybody can see the slides of Mirambika, ma'am?
Yes, Neeti, it is
We
visible.
can see, yes.
Okay, ma'am.
Mirambika, ma'am, please unmute yourself.
Can you hear me?
Yes, yes,
Hello?
we can see you. Yes, yes.
Yes, ma'am.
Can't see my slides.
Yes, ma'am. The slides are visible. I'm sharing this.
No, it is somebody else.
Ma'am, Mirambika, it's your the one you sent, Mirambika Mahapatru, ma'am.
Yeah. Okay. But I can't see it. I can see only Dr. Royar slides. So is it?
Ma'am, you have to convert that view into a speaker view.
Okay, you have to block it. If you tell you
There is the icon, yes, for the view, you have to convert it into a speaker view.
Dr. Mirambika, there is some issue with your internet connection.
Can you hear us, Mirambika, ma'am?
Somebody else.
Ma'am, if you are not able to see the slides, can you please take it without slides? You can share your audio presentation also. Are you there, Mirambika, ma'am?
Yeah. Okay. But I can't see it. I can see only Dr.
Ma'am, please,
Royar's
yes, we are seeing it.
slides.
Then just please continue with your audio presentation. Yes.
Ma'am's slides. It's okay. No.
Mirambika, ma'am, are we audible to you?
Ma'am, there is some issue with her net.
Her network is not proper actually. Her net connection is interrupting in between.
Yeah, but then is it okay? Can I hear me? Infertility. This identity one has 9. I will try. Okay now. But did you hear me?
Yes, ma'am. You are audible, ma'am.
Okay. This has resulted in multiple social constructions of demand, such as sexual devotion, female feticide, or even more number of children. This results into the cycle of vulnerability. If you see the social construction of male infertility, also science and technology has altered the social consequences. This outcome can be understood only with use of gender segregated data, and there is differing estimation of global infertility prevalence. Although male infertility contributes to more than half of all the cases of global childlessness, infertility remains a women's social burden. There is complete absence of information on the total number of infertile men. When there is high prevalence, it converts individual experiences of infertility into social phenomena. However, for male to accept infertility, it is restricted due to social pressure that threaten his position. This further limits the transformation of gender role due to lack of public discourse. While natural social construct protect masculinity of ability to produce technology and ability to identify and internalize male inability that further substantiate women's position in the family. Therefore, there is a large amount of data on the causes and management of female infertility, and male infertility continues to be investigated and treated, making women an object of experimentation. If you see the negotiation in gender relations and male are infertile, the objectification of women do affects women's position in family. In marital bargaining, women negotiate with their partners from different perspective. And in this negotiation process, men frequently have the upper hand because women are dependent. And also in the long-standing cultural mandate for motherhood, infertility affects women more than men. She often serves as a buffer for his emotional reaction to his physical incapacity to impregnate, and she takes on the burden of his infertility by defining as our infertility. Thus, the women's ability to conceive does not necessarily translate to change status or enhance her bargaining power in a relationship. If we see that child as a project, advance in reproductive technologies have allowed women greater options, such as empowering women, because infertility is an indication of the failure of the body, which brings a sense of failed personhood, which prohibits them to participate in auspicious occasions, their dignity, promote their hope, protest opportunity to become mother, father without marriage, privilege choice of age to become mother by extending pregnancy barrier, preempt gender stereotype of stigma, and therefore science fulfill more of social psychological need than merely biological. Although reproductive technologies have allowed women greater options, it is important to understand, in spite of technology advancement, the position of women. Here I present it in three aspects. First, psychological imbalance in marriage. Second, imbalance in decision for seeking treatment. And third is the criticism of reproductive technology and practice. Psychological imbalance arises due to his infertility, which results in his high-level stress, and that is found to be reasons for unable to provide desired emotional support. And although he has everything to gain and less to undergo, if she complains about the great difficulties of undergoing IVF, women face unsympathetic attitude from her partners. In this process, it is often taken for granted that she would do anything so that they might have a biological child, and she cannot demand and may not expect gratitude for his emotional labor. She makes decisions from a cognitive rather than an emotional perspective. She needs to do an extraordinary amount of emotional labor to repair the damage to his masculinity. In order to try to have both the child and to keep the relationship, it is viewed as two willing victims. If you see the decision before and during the treatment pose various challenges to women, like responsibility for initiating treatment, how to break the barrier, when to break the barrier, looking for a suitable time so that he may not get upset. In case of donor insemination, as the previous speaker said, she needs to take his consent, which is often difficult to obtain. She has to shop around facilities in the absence of information because general public doesn't have accurate information. Often she did not take the decision where to go, when, and what kind of treatment. It is her in-laws who imposed their opinions. With the amount of unsupportive and unsympathetic atmosphere from family and treatment side puts her into too much stress, leading to unsuccessful outcome. If you see the critics of reproductive technology and practice, advanced in reproductive technology have allowed women better options in either choosing or avoiding pregnancy and motherhood, but a woman's ability to make autonomous they might have biological and they cannot demand and they not expect gratitude for his emotional labor. He makes decisions from a cognitive is an important and crucial role, but cannot be addressed till the infertile remains an individual inability. It is important that regulatory guidelines are put in place to regulate the practice of IVF in India and to protect patients' rights and promote ethical practices. Unregulated industry results in exploitative and fails to distinguish by professional or professionals, and this results into multiple challenges like avenues for exploitation and include the provision of substandard services to the patient, publication of false and misleading results by clinics, deceptive advertising practices, human gamete trafficking, research carried out on gametes without the couple's consent, malpractice by corrupt fertility specialists, and unregulated ART may result in commercialization and misuse as baby producer. If you see the social construction to bridge between practice and policy, policy can always facilitate or hamper women's capacity either to choose more or to avoid it. But making choices regarding one's reproductive capacity is fundamental to widely accepted definition of human dignity and has implications for women's ability to exert influence on public sphere, where they still underrepresented at the highest level of power. Policy put in place has capable of shaping existing social constructions, and social construction of motherhood and reproductive policy suggests that public policy can be a source of change which is likely to contribute to diminishment of social inequality and encouragement of more active participation of women. Women's identity and their health have succeeded being defined beyond reproduction, but still motherhood remains central to women's status both culturally and as the object of policy. The reproductive rights movement has expanded to include efforts to establish public policy that support women's access to procedures that enhance the capacity for fertility. I would like to summarize with 6 emerging points with social construction of fertility. That is, 1, discovery and advancement of reproductive technologies marked an important milestone in development of treatment of infertility. Second, the success lies in the integration of technology with social reality. Third is social and scientific interface do affect ethics and justice, while social construction more impact women justice. And scientific interventions are constantly negotiating ethics between production and performance. Setting up ethical guidelines in urgency, not just for biomedical practices, but for the social, economic, and political practices that determines people's illness, health, and well-being. Those women who wish to be mother outside the traditional heterosexual family structure will still prove vulnerability of their position. Therefore, if above issues are keenly addressed, then women's involvement and participation in the healthcare system and the global reproductive marketplace can be encouraged and enhanced. In order to take it forward, I have classified it into 3 dimensions, that is policy, advocacy, and practice. Intervention in isolation may not work. On policy issues, 5 points are critical, such as conceptualization and categorization, that is defining inclusion parameters for infertility, regulation code of ethics and SOPs, mandatory disclosure, that is informed consent, more information, the risk and the role of men, failure rates, etc. Program integration of infertility services into the state's reproductive health program, and research on prevalent psychosocial aspect influencing outcome that needs to be established. While advocacy requires important aspects such as accessibility, building awareness, affordability, and acceptability. And lastly, practice should focus on effective counseling on coping with psychosocial and sexual problems, particularly counseling the partner. And finally, the capacity building of the providers on attitude, behavior, and empathetic understanding of our circumstances. Thank you so much. Hello.
Thank you, ma'am, for your excellent talk. Dr. Pramila, can you please conclude the session of ma'am's talk? Dr. Pramila, are you here?
Good evening, everyone. First of all, I would like to congratulate the IFS team for conducting such excellent workshops on a virtual platform. All the talks had been excellent. Thanks a lot to all the chairpersons and the speakers for joining the sessions. And we look forward to the IFS conference on the next weekend and post-conference workshop. Thank you so much.
Neeti, please take over.
Yes, ma'am, I was muted. Pramila, ma'am, please introduce Dr. Sophia Gamerio, ma'am, so that she can take the next lecture.
See, Neeti, we are not able to contact Dr. Sophia. I guess she has not joined the session till yet.
Okay, ma'am.
Okay, so please
let's
call on the other chairpersons. They will conclude the session.
Yes, ma'am. I'll request Mala, ma'am, to please conclude the session.
Dr. Mala, are you here?
In case Mala ma'am is not here, Dr. Ritu Jain ma'am, can you conclude the session?
Dr. Ritu Jain, are you here? Okay, next chairperson, call next chairperson, dear.
Ma'am, Roya, okay. So, Roya Rosati ma'am, are you here? Can you conclude the session?
Yes. In session 3, we have 2 talks. Dr. Rima Dada gave the talk on need to integrate yoga into infertility treatment, which was concluded a good talk when, of course, multi-center study need to be carried out. Still, scientific evidence-based medicine has to be established. And the second talk was social construction of infertility and changing gender relation by Dr. Mirambika. Was an excellent talk. Now the session is open for the question and answer. Any questions?
We have nicely seen that all the infertility treatment can be nicely coordinated with different kind of modalities of treatment. And that is the need of the hour.
Can I ask one question from Dr. Rima Dada?
Yes, ma'am.
What was the exact yoga practice which was taken up in this study? What asanas, pranayams, exactly? What kind of yoga was done in this study? Rima Dada.
I think she is not there. Is she there?
She has left.
She is left.
Okay.
That time we should have asked her. Yes.
a small reminder for the quiz. So we
Yes.
are having quiz at 6 p.m. So please, you just download the app Kahoot and you will see the questions in your laptop. Maximum time is 30 seconds. So please be ready for the quiz as well. Our next session, let's move on to the next session. That will be the last session for the day and very, very interesting panel discussion. So I would like Roya Rujati ma'am to take over and introduce the moderators, please.
Yes, this session is on the case presentation and this discussion. The moderator is our President-elect, Professor K.D. Nair, welcome sir, and Dr. Anupama Bahadur. And the panelists are Dr. Richa Agarwal, Roma Satwik, and Raja Lakshmi Mundra, Joan Gardwani, and Sandra Batman, and Rita Bakshi, Surjit Kaur. Yes, sir. Dr. K.D. Nair, sir, please take over.
Good evening, ladies and gentlemen. Good evening, ma'am.
Good evening, sir.
So we have to carry on with our panel.
Actually, we are not able to connect with Sandra and Jones and also Dr. Sophia also. So unfortunately, we have to proceed to the panel. So at the last of the panel, we can conclude the session.
Yeah, maybe in the meantime, we can keep on trying to.
Yeah, we are trying, sir. So after the panel, if it is, we'll approach them, then we'll keep their talk.
Yeah.
Okay.
My co-moderator is Dr. Anupama Bahadur.
Good evening,
Let her
sir.
take over from here. Dr. Anupama.
Good evening, sir. So we have an esteemed panelist, Dr. Richa Agarwal. Sir, can you have the next slide, please?
Yeah.
So she's a counseling psychologist from Gauri Ridge IVF Center, Delhi. Joanne Karwadine is a private counselor specializing in child abuse, fertility, and couples psychotherapy. Sandra Bateman, she's a senior fertility counselor practicing in reproductive health. And both Joanne and Sandra are from United Kingdom. Dr. Rita Bakshi is a senior consultant in fertility and endoscopy surgeon. She's a very renowned IVF specialist and is the chairperson of RISA IVF and International Fertility Center. Dr. Surjit Kaur is the director, Parivar IVF Center and president, Jalandhar Obs and Gynae Society. Dr. Ruma Satwik, she's a consultant at Center of IVF and Human Reproduction from Sir Gangaram Hospital, New Delhi, and has been practicing since 2010 over there. She has a special interest in research methodology and did a wonderful workshop in the morning session. And Dr. Rajlakshmi Mundra is an assistant professor at AIIMS Rishikesh with special interest in oncofertility. So I welcome all the panelists and I hand over the session to Dr. K.D. Nair, my co-moderator.
Well, we start with the first case scenario, that is pre-IVF anxiety. Most of the IVF consultant, we see this in and out in our practice every day. We had this couple, this American patient coming to our clinic with a husband for an IVF. The couple appeared very cheerful, talkative, hale and hearty. And the husband left after giving the required semen sample. Then we noticed that she was getting jittery, anxious, and on the OT table, when we put her up for pickup, she got up saying she had a rash on her legs. She suspected cancer. She wanted it to be tested. We did an IVF for her and it failed. After the failure, her anxiety had increased. So we would like to know, you see, actually we have put the name of each one consultant probably because we are now enough time. We can ask the opinion of 2 or 3 panelists. How to go about in this scenario of pre-IVF anxiety? Dr. Richa, what is your, how you will handle it?
Thank you, sir. Thank you for the question. Sir, actually, as you have explained the case, superficially, only in these 4 lines, so many things are, visible, like the anxiousness of the patient, hypochondriasis, mood fluctuations. Sometimes she's getting happy and suddenly she has turned into, like she's becoming anxious and worried. So much of psychological issues are there to see. As we all see that when a patient comes for an IVF, though we will do the prep, every aspect of, carrying the IVF further, we take all, like we'll do all scanning, we'll do all the testings, blood tests, whatever is required, it's been done. But same is not done for the psychological well-being of the patient. And like what we can do is, in this case, it is very important that the psychological counseling of the patient, like assessment, need to be done. As Dr. Poonam Nair has also shared, there are 20% cases who are at high risk. So I really am not sure how much the anxiety or stress level affect the outcome of the IVF, but definitely it will become it will make the journey for the patient very, very, smooth, and the anxiety level can be controlled either with medications or so many things which we can take care of, because the background from which the patient is coming, it is like, it could be a financial aspect, it could be a social support. Maybe in this case, we can see that there is no one to support the female over here. And there could be any, like maybe the patient is quite, her EQ is quite low. So there are many aspects which we have to take care of psychologically. So what we can do is, like, we should follow same way we follow the procedure for IVF, we should follow same way in a step by step. Like first thing which need to be done is the assessment of the patient. As it has been shared, like screen IVF, and we have PHQ-9. So many things we can check out: the depression level, anxiety level, social support level, everything can be done in a stepwise manner. And then what we can do next is, like, first thing to do is assess the patient, then provide the adequate information to the patient about the whole process. What, like in any way, like if it is how it is going to affect her financially, how is it going to like how the process will go, actually how many injections, how many cycles, the waiting period, as the waiting period is the most difficult task to do for the patient itself. So then next step which we can take is, we can find out, while we have assessed the patient, then we have to find the core thing, what actually the cause of stress is. In this case, definitely I can see, like, the patient is very much considerate about the result, and she is also lonely because nobody is there to support her. So we can, give that support. If she is really not having that support from on the family level, that could be arranged. We have so many support groups. There are so many people in our center who are coming for the same thing. So we can make her in contact, make her come in the contact of that person. So this will also help. Then comes, like, once we identify what the situation, what problem is there, what is causing anxiety in the patient, then we can, with CBT and many other therapies, we can make her learn what is the irrational way of thinking, and how we can, modulate or change that way of thinking and make her more less anxious. Then we can, there are many things which we can, like allotting time for your worries, then penning down their thoughts. So there are many things which we can use with the patient. First, we really need to analyze what the problem actually is. And then the last step comes, which is the self-care. We really need to inculcate that habit into the patient, because that, be it meditation, be it deep breathing, be it progressive muscle relaxation, be it yoga, as Dr. Rima Dada had explained it so well about all that. So all these things will definitely help the patient to come out of this anxiety provoking situation. I am not known like how will it affect her results of IVF, but definitely it will make smooth, the journey will be smooth for her. And also we should be very empathetic and actively listen before prompting to her question. We should actively listen to the patient and probe her to tell us more about her, so that she could be made like she should be made less anxious and more in a way to accept whatever the result may be for the future. So that is my suggestion is.
Dr. Richa, you see, if you look at this short history which we are given, there are a few things which are very prominent.
Yeah.
This patient has come all the way from USA, traveled to India for the IVF. And the husband is left after giving the semen sample, freeze the sample and use it whenever you do the pickup. And thereafter, patient is totally on her own. Whenever we have a couple like this, where the husband is even in India living just after giving a semen sample and leaving the woman on her own, she is likely to have more of these anxiety issues post failure, or even with pregnancy also, she can have more of this anxiety issues. I'd like to ask, you see, the other clinician in the panel, Dr. Rita Bakshi, how she come across such a scenario in her practice, that the husband, the couple coming from outside and husband giving the sample and leaving, and the woman is there to face all the procedure on her own. Dr. Rita, what is your...
Sir, actually, like what you're talking, Dr. Rita?
Yeah, Dr. Rita Bakshi is a clinician, so that is why I'm asking.
Okay, so sorry. Go ahead.
She's there?
Mute. She's
Dr. Rita.
Yes, Dr. Nair. Sorry.
Yeah.
Muted now.
Yeah.
Thank you, Dr. Nair, for, because, and I'm very happy you've taken some of the cases which are this patient was actually in my clinic. And, what was my fear, let me tell you, was because when she used to go back, then when her jitteriness was increasing, I was so scared. And at that time, I was actually even scared that she may even commit suicide. That was the level of jitteriness. I was so bothered that I wanted to ring up the American embassy for this patient and be, because especially, when we are tackling patients from abroad. And I don't know how other people are doing, but, except when as Dr. Nair said, the husband was there, they looked very cheerful, talkative. They looked absolutely like a normal couple. But when he had left, I don't know whether, and of course, later on, she did give us a history that, they had other issues and which you cannot really find out all over, when you are doing. So it is so important to have a counselor in your clinic whose only job is to, work on this anxiety part. So as I remember in this case, fortunately, there was a person from embassy coming in, and I put the two together and I said, please take care of her because I'm really, really worried about it. But I think, Dr. Nair, most of us as clinicians are doing our job, of taking out eggs, putting in embryo transfers, but not really getting into the anxiety part. It is natural whether people from abroad or here, their anxiety levels have it's so high, so high.
I wanted to ask Dr. Richa Agarwal, you are a psychologist, ma'am. In a scenario like this, when the husband is leaving just after giving a semen sample and leaving the wife to face all the procedure on her own, will you not like to go further into her psychological aspect?
Definitely, sir. Definitely. In this case, particularly in this case, one-on-one counseling, one-on-one support. At least one person should always be there with her to support her psychologically, because the process she is going on, and above that, she is having so many psychological issues beforehand only. So it is very important that that's what I mentioned, that if there is no one to take care of her personally, then there should be, the husband should be asked for, like, as today we are also taking help of virtual world. So then they could connect, on a video calling, and the husband should be asked to take care of her from distance only. If he cannot be present physically with her, then we can, like as ma'am, she had more patients of IVF who are, sailing in the same boat. And that thing, gives a very good feeling when that, okay, I am not the only one who is going through all this. So there are other persons as well. And when they'll share their stories together, so definitely some relief you will get at some or the other level. So this is the way we can help her out.
Because this patient definitely looks, when she is there, when the husband had left after giving a semen sample, that she is likely to develop some sort of a psychological issue. And probably it was there prior to her coming to India also, you see.
Definitely, it would have been. It doesn't occur in a one, just one incident will not cause this. It is the basic personality or nature of the patient. That is why it is very important that while we are taking care of the IVF cycle, we should take care of the psychological aspect. So that is really, it becomes really important to find the support. And because there are sudden mood fluctuations are there in the patient. She is so happy and suddenly she becomes so focused about that little patch of, redness is making her think that she's got cancer. So that is what she is really becoming anxious. Although there are certain childhood, traumas which may lead to all this, but since we don't have that much of time to, go in depth for that thing, but we can, at present, we can cure the current things which are happening with her, and later on, we can like tackle all that core beliefs, her, deep thoughts that can be taken care of later. But for current level, we have to treat whatever, symptom she is causing currently. So that is a very important part to take care of.
Dr. Ruma, she is there?
Yes, I'm there. I'm there.
Dr. Ruma.
Yeah.
What is your take on this case?
On this particular case?
Yeah.
All right. So I can only speak from the point of view of clinician. And first of all, let me say that Dr. Richa has elaborated on most points very beautifully. And like Dr. Rita here, even I would think that, looking at the psychological aspect of the patient is equally important. But I do feel this, and this entirely comes from my experience kind of situation, is that patients need a confidant. And it's not just a patient, it's anyone who's going through a stressful situation needs someone to speak with. And the husband clearly, his absence makes some problems here with the patient, and she gets very, very jittery and very anxious. But the other issue is also that, as Dr. Richa elaborated, is it's also in her personality to kind of get too jittery, get too anxious. So we do have women who tend to get their treatments on their own. Not everyone would go through this kind of anxiety. So I'm going back to that concern of confidant, of who someone she can rely on or she can speak to. So in a foreign city, foreign land, the person who she's trusted the most is perhaps you yourself. And so it helps to perhaps identify this problem, to speak to her in a way where she maybe comes out with her deepest anxieties, and for you to be able to address them in a way that that reassures her that, okay, this one is there and I've come to her maybe or him and this is the right place for me. This might address some of her anxieties, although not completely. If I feel that my talking, and this is like, and I'm meeting her maybe every day over the next 15 days, and if I feel that that address or that kind of speaking to her hasn't helped her at all, I perhaps then of course seek the help of a counselor. I seek the help of a psychologist or a psychiatrist, in fact, to see if this is something more serious than what I imagine it to be, and if she needs to be on therapy, in which case, and if that is the case, maybe it could be, there is a very slight possibility that could be the case, I would want to definitely withhold her IVF, because this needs attention right now. We would want to address this first before going into IVF. So I'm not saying that everything is functional. Some of this could be organic as well, and that organic bit needs to be taken care of through psychotherapy or pharmacotherapy.
So can I just add in a few lines, Dr. Nair? So I think IVF, we all understand, is a very, very stressful for everybody. I'm also more bothered on, and this gives food for thought for everybody, especially for people who come from abroad. You know, they get their, of course, license to come here for treatment. But then, and this is not uncommon, whether it is any country, and then they leave, you know, and this is, as we said, this is a normal thing. So, and especially in her case, you know, I actually thought, you know, as we used to look at her, see, it's very easy to say cancel cycle. She's come from abroad. She's staying for a very little while. Her stimulation is going on. We are showing her to a psychologist. I mean, she's getting treated there also with the counselor. But what I'm just saying is, I don't know what kind of litigation also we can follow, as sometimes, you know, when people from abroad, and then what kind of rules are there? We on our own will, of course, you know, look at people. So like I found the support system in the embassy itself, but that may not be possible every time. So I really don't know. I mean, you know, I know it's very easy for us to think and probably logical to cancel cycles, but cancellation may not be, you know, her anxiety may have, you know, maybe even have higher because she was here staying alone a long time only for this purpose. So I think this really looks, you know, especially for people coming from abroad, we should also think in some other ways and always look at support systems in a local place whenever they're coming here for treatment.
Yeah, you see, whenever we have a patient wife staying back alone, she need to have some sort of a confidant available to her. You see, we had a similar patient coming from Afghanistan. The husband left after giving semen sample. We did a pickup, we did embryo transfer, and she stayed back in a guest house just opposite our hospital. And what she was waiting for her pregnancy test to happen after 15 days, and what she was doing during all this time, so almost for 20 days, she will walk into our clinic every day, sit in the reception, talk to my girls, and with one of the girls, she became more friendly. She will spend 3-4 hours, even after I leave, she will spend 3-4 hours talking to the girl, taking her out for a lunch, and their bonding developed between these two, you see. At the end of it, she was absolutely alone, living in a guest house, but she really went through the whole procedure very nicely because she could find some local sport here in Delhi. Probably this is what we also have to look in such a patient who are coming from abroad, that we must put it in our mind that it is better to have some local sport for them ready. They should be told from the very beginning, okay, you can have interaction with this particular assistant or doctor or whatever it is, so that they know in their mind that this is the support system which is available to them. That is my feeling. I don't know if other people agree or not.
Absolutely agreed, sir.
Dr. Anupama, take this case.
Okay. So Dinesh, he came with his brother and sister-in-law, aged 40 years for IVF, and the treatment was done successfully. So he then came back again with his wife, 43 years old, on doing an IVF cycle. All limited success at the age of 43 were duly explained and signed. Yet when the result came, it was negative, and his rage knew no bounds. He called the media hooligans. He tried to break the hospital. So Dr. Uma Sathwik, how will you handle him now? Dr. Uma?
Yeah, hi, I'm back on. No, I was just wondering if this is a real life case or...
It is, Uma. This is my case also, and I will tell you what I did.
All right. No, I would really want to hear from you. But
Yeah.
again, it is my experience in quotations that I'll be talking about. Again, my understanding of the case, not experience. But clearly, so here there has been a successful cycle in the family. And thereafter, when he does come with his wife and he has clearly been explained that such and such thing will happen, or the success rates are low, and when the results are negative, of course, he is so angry that he comes in with hooligans, right? So to break the hospital, and probably also has, if he has sort of, he's right there in front of you, he's probably really angry, not open to reasoning or talking right now, and he has got all these multiple people with him. There are three things that are immediately coming to my mind. One is that there is immediate threat of physical violence, and that threat is so immediate that that needs to be addressed right away. That's one. Second is the other thing, I'll be addressing that. I'll try and answer that. Second is, of course, one needs to understand why this person, despite all the explanation, is in such a state. It is really unusual for people to behave in that manner. Is he genuinely aggressive? Is it something else that is causing him to be like that? So maybe hear his side of the story, what the others are saying. And well, media is very difficult to handle. I wouldn't be saying much about that. But the third bit is, so we are trying to think in our heads, what is it that we may have done wrong and how exactly to address that. So so the first issue that comes to my head is that of immediate physical violence and physical threat. And that, of course, you want to immediately alert the security. You want to immediately alert the medical superintendent of your hospital or whoever is responsible for administration of your hospital, and make sure that you're not alone in the same room with these people. So as much as possible, get your staff to be around you. Second is, of course, you have to be calm if you are directly confronted with maybe 7 very angry men or women, whoever they are. It is important to stay calm and to speak to the most, and look at the most angry man in his eyes and try and hear him out. So as much as possible, ask him to speak. What is it that he's trying to do? Is it just this? So maybe allow him to vent his anger. That venting might maybe reduce some of the rage that he's feeling, because he's able to say so many things to you. But are we going back to the slide? Although I don't need it, but yeah. So the venting of anger might help in, am I audible?
Sir, can we go? Yeah, you're audible, Dr. Rumak. Sir, can we go back to the slide, please? We've moved ahead.
Just to take a pause, we just want to welcome Dr. Sophia. She's here with us. She is the ISHRI SIJ and Counseling. Dr. Sophia, can you join in the panel till your talk? We'll start your talk.
Yes, hello. It's a great pleasure to be here. Thanks so much for the invitation from the Indian Society. Can you hear me? Can you confirm you can hear me?
Yes, ma'am, we can hear you.
Yeah, so I'm ready to start the talk whenever you want.
Okay, Dr. Katie, can you please include her in the panel, and after that we can have a talk? Dr. Anupama?
Yeah, sure.
Yeah. Please involve her in the panel also. After that, we can have a talk also.
Okay.
Okay, we are not able to approach Joan and Sandra, so please involve her in the panel.
Sure.
Okay, thank you.
Okay. Sir, can we go back to the slide, please?
Yeah.
The previous one, sir.
Just 1 second.
Dr. Ruma was there.
Yeah, I was just talking about the immediate physical threat and how to handle it. I was just talking about how to address the most angry man and allow him or her to vent his anger, I'll ask him to speak, and as much as possible, ask him why he is or she is so angry. And this allows maybe some of the anger to come down. And now, of course, you are looking at what has caused him to be so angry. So basically at this point, when the anger has settled a little, you try and explain to him and his the whole lot that he's come with is what IVF is. Perhaps at this point, you can slowly introduce the idea of how IVF is not always successful and how this was explained to you, right? And perhaps, after that rate settles, you probably have many people around you, and they will probably not undertake any physical violence or threat at this point. So that is what I would feel. But number 3 is that I would also try and look at his extremely unusual reaction here. And is it because the counseling was not proper? That is one that I'm looking at my end also. Was the counseling improper? Was he not told about what IVF entails? And that does success happen all the time? Is it because, he's just upset that the brother and sister-in-law, there could be internal strife in the family, that one family got a child and that they could not, and maybe try and address that, and how maybe another cycle or a third cycle, or what his future options are, that this is not the end of life for him and his wife. There are other things that one can do for them in order for them to have a baby, maybe another cycle or a third cycle, of course, with limited success, or other options could be explained at this point, that this is not the end. There are other things that can still happen. So at least as a clinician, this is what I can think at. Just one last point is, like I said, unusual rage is, are we dealing with something, an organic psychological cause, and that needs to be addressed. Maybe when he has calmed down, maybe we get a psychiatrist to assess this man as well.
Very beautifully summed up, Dr. Roma. And I would be worried about domestic violence also. If he can, bring in the hooligans to your hospital and try to break it down, I would, be a little worried about his wife, with whom he could have raised his hand or, put the entire blame on her. Having said that, Dr. Rita, we would like to know how you handled this case.
Yeah. So I think Dr. Ruma, you answered very nicely the whole thing. And, whenever we are faced with situations like this, this can happen in a road rage, it can happen anywhere. So what happened was, we were very, very clear. We knew his wife was 43. We know the results. Statistically, we explained to him each and every result. I think what I probably did, he looked like a puppy Lyri, he was wearing at least 20 gold chains, and that itself should have probably given me some hint on somewhere something not right. But when you are doing duly explaining and getting all consent forms in place, but when the results come negative, and thankfully, he called the media. I mean, I remember, that Z wale, ye wale, sab ladke le, aa jao, idhar aa jao, is hospital ko tod dete hain, ye, and at that moment, I was feeling defenseless. I was feeling, what am I doing here? I mean, I've done everything right. I've done nothing wrong. And yet here I am, and maybe, with media swooping on, and this is the thing the media wants. So, of course, from that time, I thought I required maybe some goons around for myself for, getting protected. But what really worked was that while he was doing all that, then I started, I said, did I not explain it to you? Were you not aware of this? I did tell you at 43 results are not there. And just because your sister-in-law got it at this does not mean. But, and then finally what worked was what you said last, that, at some moment in that talk before people could arrive, he understood that one thing that probably works is if you say no money. So I said, okay, the next cycle we'll look at. And let's not talk about money at all at this point. Maybe I'll explain it to you about the donor, and we've done that already previously. But I said, we'll look at other options. And as we said, the same thing, that options are there. So I think that probably calmed him for the time being, and the accident was averted. This is what happened. So, and I think he understood, because the next time he came, he was much calmer, probably realized his mistake. He thought that he had not behaved well. And after that, and fortunately for us, he didn't come back to us for treatment. So that finished the story for us.
Wonderful. We faced this in our medicine ward, actually. We had a terminally ill patient whose CPR was going on. And once the relatives got to know that, they were given the news that he's no more. So they went violent and they started running after the doctors and the staff nurses, and the doctor on duty had to literally shut himself in one of the doctor's duty room. And the relatives, they managed to injure the staff nurse. So we had to call the police, and it gets bad at times because one is not ready to accept the situation, and that is when they have a problem. So Dr. Richa, would you like to add in here? How would you have counseled this gentleman who did not behave in a very gentleman fashion?
I think Dr. Ruma and Dr. Rita has explained so well, and this is the protocol which we should follow with such fellow beings, because I think when he must have, while the cycle was planned, he must have visited her to you, ma'am. So definitely you must be, as you are saying, he was looking like a Bapil Harry and he was wearing chains and all that. So you can make out like what the reaction of the patient would be. As we can make out with the female, like she'll cry like hell or whatever it is. So we really need to get prepared, as many hospitals are not only for the IVF negativity, as ma'am has also told, like terminally ill patients also get, patients, relatives get aggressive in that way. So we really need to get prepared for all that stuff in the way that Dr. Ruma said, we should not be alone at that time. That is the best thing to do. Like we should never be alone at that moment. And then definitely it is always, anger is just like, fire. It will, spread like this and it will come also down very soon. So if he is not throwing things, not distracting anything, let him be on his yelling part. Let him get through that. Let him speak. We should not interrupt in between. If it is only verbally he is doing something. So once that all will be, out, he went out, all that stuff, then he will himself realize that, oh, I was wrong, what all I have said, as it happened in your case, Dr. Rita. So that is the best way to do. Like let him went out, but in a very safe manner, in all the security, and we should have that on prior notice, actually. That's it.
Dr. Anupama.
Yes, sir.
I think Dr. Sophia is with us. She has joined us.
Wonderful, sir.
I don't know. Dr. Sophia, you are there?
Yes, I am here. Yes.
This is Dr. Nair. We were just discussing few case scenarios in our day-to-day practice here. And in this particular case scenario, which we are highlighting here, a 43-year-old woman, she failed with IVF cycle and husband was in a rage. He was calling media and hooligans to break the hospital. Do you have a similar situation in your place in UK? Have you ever experienced such a similar situation that after a failed IVF at the age of 43, somebody becomes so mad?
Well, first of all, I'm not a clinician, so yeah. I'm mostly a researcher. But yes, it's a common situation that, when faced with failure and faced with serious barriers to just realizing your parenthood goal, people would react with the most extreme reactions. And there's a lot of research showing that it's a true grief process, and we know that the initial stages of grief, in a way, are denial and anger. So these are common emotions when you're faced with loss of something that it's so central in one's life.
Yeah, that's okay. But do the husband go to the extent of say creating a ruckus, breaking the window pans and this thing? Does it have?
Well, that would be considered quite extreme reactions. So I mean, we know that a very small proportion of patients can really have extreme kind of psychological reactions that we could consider and classify in a more kind of, in the realm of mental health, clinically significant. And I guess such extreme behavior, you would think if it would classify in that area, but it will be a minority, a minority of patients.
Thank you, ma'am. Thank you for your expert comment.
Thank you. I thought I'm sure their penalties are much higher, and I'm sure they're more scared of law there than people here.
Yes, maybe. Yeah.
We go to the next case scenario. Dr. Anupama,
Yes, sir.
this is not moving. Slide.
Sir, please click on the slide once.
Click on the
slide. Just click on the slide and just try now.
Yeah.
Yeah.
Okay. The next case scenario is sperm donation, the gamete donation. Kamla came with her 2 sons to our OPD. Ankit was diagnosed with aerospermia, while the brother Rahul was blessed with twins. So the mother wanted the son to donate his sperm for his brother. And we can sense the discomfort in both the husband and wife part. You see, this is a case scenario very common in India, that people are thinking of genetics, genes from the same family. That is why this mother wanted the one son to donate the sperm for his other son who is aerospermia. Technically, by law, as per our ICMR, you cannot use a known donor. But this is generally what is happening in our day-to-day practice, that the mother-in-law wants his son to donate like this. Actually, this question was for Dr. Jones. She has not joined. She has not been able to join. Dr. Raj Lakshmi, she is there.
I think she is a little busy in some emergency, sir. There's an eclampsia patient who's there.
I guess Dr. Surjit has also joined, sir.
Okay, Dr. Surjit. What you will do in such a case, ma'am? Dr. Surjit has joined or not?
Good evening,
Hello?
sir. I am here. I am
Yeah.
audible?
Yeah, Dr. Surjit.
Good evening, sir. So, this is a common scenario in our India. So many people or families, they quite frequently come and ask for such things for relatives sperm donation. So in these cases, we have to just counsel very deeply, or we should be very much connected with them and advise them not to do this, because this is against all their problems with the next baby that is born. And so many problems are there in the family for the property, and other issues are also created. So such things should not be done in the family. It's really difficult to make them understand such thing, or they always are adamant. Or I have seen the people coming, and there was a person who was living in front of our house, hospital only. They were having a chemist shop. The son died. The family came for his father-in-law's semen insemination to the daughter-in-law to have the next issue. So such issues are quite often come across, and we can only counsel them and convince them that this is should be done through the semen bank only. So
Dr.
counseling only is only important in this patient. Otherwise, in our India, people are having a strong feelings to have the same genetic material of the family to go. So,
should I take this, sir?
Yeah, Dr. Sophia.
Okay.
Hello?
Yes.
Yeah, Dr. Sophia. What about in England? You have the same scenario that you want, the people want from the same gametes from the same family, or they are looking for anonymous from outside?
No, this is not a common scenario in the UK.
Mm-hmm.
And
you have to go for anonymous.
Exactly.
Isn't it?
Yeah. Yeah.
You can't have it from your own family.
No.
That's great.
Yeah.
Should I take this, sir?
Yeah.
Yeah. So it again comes from my experience and what our values are in terms of how we see our patients. So for me, in a situation like this, if I'm treating, could we go back to the previous slide? Yeah, Aniket and his wife. To me, Aniket and his wife and their opinion is more important than Kamala, their mother. And I lay a lot of importance on patient autonomy and their ability to make decisions on their own. And that is what I would want to encourage. Clearly, the discomfort here is on the part of Aniket and his wife, and very rightly so. There are multiple reasons for this. First of all, the social setup that we are in, you use, let's say, a known donor's sperm, and where the donor lives in the same family as the couple, I mean, I'm sure there are different experiences from different setups, but some experience from what I know of also states that here the person who has twins, Rahul, is, I mean, having donated his sperm to his brother's wife, somehow makes him a claimant to the wife as well. And there could be other scenarios where Aniket gets to take a lesser situation in the family or a lesser position in the family. So his discomfort is completely justified. And no matter how close the brothers are, I would also look at other aspects. The aspect would be, of course, the social aspect that I talk about, the discomfort of the wife who will be very uncomfortable using the brother-in-law's sperm. Number 3 would be the legal aspect, is once the child is born, who lays claim to whose property. I think those are the issues why ICMR guidelines also state why sperm or gamete from a known donor, especially from, within the family, should not be used. So property issues, social issues, familial issues, and of course the primary issue of autonomy, which has not been addressed at all. And I would want to lay a lot of importance there. So definitely I'm not going to encourage this. Also, I would counsel Kamala on all these problems. These are the 3 things I'm looking at, and why you need to stop asking for Rahul's sperm in your wife's, in Aniket's wife's case. That's my submission.
Thank you, Dr. Ruma. We go on to the next case scenario. Dr. Anupama can take it further. Dr. Anupama is there?
Yes, sir, I'm here.
Yeah, go ahead.
Sir, I'm sorry, actually, there's an emergency in the hospital, so
Okay.
I just muted myself because there's some case that has come in the COVID. Okay, so we had a husband who was unable to deposit the sample on the day of the IUI, and he's very anxious and says that he has situational anxiety. The stress at work and the stress of infertility gets to him. But on further discussion, he revealed that he has an extramarital affair and he cannot produce the sample for his wife on that day. He was counseled and subsequently was able to provide the sample for IVF treatment 4 months later. This was actually to Sandra, but since she's not there, Dr. Rita, I'm sure you face this kind of a scenario in your day-to-day practice. How would you go about this patient?
Yeah, so I think this is absolutely extremely common. And even if he was not having an extramarital affair, it is the anxiety, especially, I find that in IVF, probably this is the most difficult part, when you just ask a man or the sporapher and say, go, okay, you have to give a sample. And this can definitely, I think this is where, if we deposit, this is where first talking to them, so asking the couple whether it will be difficult at that time to give a sample or will it be okay. So the first thing that we ask, whether it is an IUI or IVF, that will he be able to give a sample on that day, or would he want us to have a sample, backup sample frozen before, just as a backup in case he's not able to give that day. In IVF, we take a backup sample for all. We don't take it to chance there. IUI, one can still, get them to have coitus or do whatever. And as we can see that maybe, this is where counselors have such a huge role in IVF and IUI cycles, because it is only later that we realize that he had an extramarital affair. And, probably giving a sample they may not be having a proper consummated life itself. It was not only that day, it would have been any other day. So, and this is what probably worked also, because when he was counseled and he was able to give the sample for whether it was IUI, IVF, whatever happened. I think counseling and backup samples and talking before taking on these cycles and knowing how difficult it would be and realizing the sensitivity of getting a sample. There are a lot of centers where, they have to just go to the washroom and give a sample. It's not easy, people knocking on the door. So giving them proper place where they can deposit the sample and knowing beforehand whether it would be difficult or would be easy. So I think that's where what is required.
Situation, a husband not able to give sample and he's anxious, stressed out. The clinician will give him some talk. Still he is not able to give the sample. How you will tackle this type of husband? Dr. Richa is there?
Yes, sir.
How you will tackle?
So in this case also, like pre-counseling is very, very important, as the anxiety level, mostly it is seen that anxiety level is more in the female and less in male. But in some cases, there are males also who get anxious, and as in this case it happened, like he was unable to give the sample at that moment. So that's why it becomes mandatory to assess both the patients, male and female together, to the anxiety levels. So, and if really we are planning going for an IUI or we are going for an IVF, then we really need to start one-on-one session on, almost weekly thrice or weekly 4 times. In that, what will happen is when the time will come, the patient's way of thinking and way of acting to a situation will definitely change with the course of action we will take as a psychologist. And he will learn how to control his anxiety, how to manage that level, and how just it happens many a times when we are there on an exam, before an examination is given, we feel that kind of anxiety. It goes up, it seems that everything is blank, we won't be able to do that. So when we go step by step for that, it will not happen in a day, but we really need to give patient that time before we are planning a cycle. If we find he is really anxious, so we really need to prepare that patient for that thing and then go ahead with the session. And then that, as Dr. Rita has said, we said we should have a backup sample always available. And that also would be possible when the patient is able to give the sample actually. So, and it would be when the anxiety is controlled. So there are step by step, as I had said in the previous one, we really need to know his thought patterns. Is he into an irrational way of thinking? Then we have to rationalize that thought pattern, like nothing will happen. There are many things and many exercises to control. We can give the sexual education to the client. Very clearly it should be mentioned, like we can go ahead with Kegel exercises, pelvic floor exercises, controlling his, urine incontinence, and all that things will definitely help him overcome that anxiety, and he would be more, it would be more easier for him to give the sample then.
But do you accept his excuse that because he is having an extramarital affair, he cannot produce a sample?
No, that is not.
This is a simple excuse he's giving you.
Yes. That is, it is just he's covering his weakness under that carpet. You can say that.
Thank you, ma'am.
Yeah.
Dr. Anupama.
Yes, sir.
Take the question.
Okay. So this one is for Dr. Rita Bakshi. Anil and Neha, they have an autistic child from a previous IVF despite PGS cycle. They're petrified. What else can they do? and they're inquiring. So can it be prevented by using an egg donor, and what will they do if any genetic defect appear? Yes, ma'am.
Yes. So this is again a very realistic scenario, and I have a Supreme Court couple, judge and his wife, coming in with exactly the same thing. They have an autistic child, despite a PGS cycle. I think what is again important, because we are sitting in a counseling workshop and realizing that, telling them that even if you are doing a PGS, you cannot prevent every single disease known on the earth. So I'm sensitive. I understand that having an autistic child, and just to say that autism has risen to the tune of 1:59. I mean, that's the kind of spectrum that we are seeing. Also, understanding that autism can be mild, it can be severe, and there are, in the severe form, maybe a Fragile X syndrome or any structural microdeletion, something that you can work out from a PGS. But in 50% of the cases of autism, where it is not known whether it is genetics or environmental or, older paternally, the sperm defects, whatever could be the cause, we cannot guarantee, we cannot ensure that the next child will be free from autism or any other genetic defect as they are asking for. Now, doing a couple's detailed screening, a detailed NGS screening for both the couples genetically, ruling out that whatever, genetically we can. Once we have done that, can it be prevented using an egg donor? Because, in this case, I don't know the age of the wife, and it has been seen that autism is more common in males, and to the tune of 4 or 5:1. So it is also important that it could be an X-linked, which is getting, so we really don't know. Let me say that genetically, we are not sure what is the cause. So counseling again takes paramount importance in any case where there is a genetically affected child. If we can work out in detailed genetics and find out the cause and then prevent it through PGS, PGT, A, M, or whatever reason we can, but we can't. And if every disease is not possible to be, and it is not clear that it has only a genetic basis, then I think counseling and telling them that we will not be able to give, a guarantee on to the couple that this child will not be 100% unaffected. I think in every disease, which doesn't have a firm genetic basis, which can of course be, PGD, PGS or PGT has for in a large number able to help, where but in sporadic mutation and environmental effects, in so many others where we really don't know what is the 100% cause of the disease, those diseases will not be able to be covered by a PGS cycle also.
Dr. Ruma, you have this genetic center in your hospital. How do you deal with such
I agree with Dr. Rita completely here. It's a completely, I would say, a condition that we do not know the origins of. Some genes may have been located, but it's such a broad spectrum disorder that you cannot detect the condition based on a genetic analysis alone. And what PGT is offering is just a chromosomal number assessment and nothing beyond that. And we know that genetic diseases extend beyond that. It's a single gene disorder. It could be, something to do with folding. It could have to do with, epigenetics, or some factors later which interact with the genes and cause either expression or silencing of those genes. So one really isn't sure how this is caused, although yes, age matters. There could be maybe a slightly stronger association with, let's say, a history of an affected child in the father's family or the mother's family. But it's very difficult to determine or ascertain by tests alone. And once again, egg donor does not ensure that you will have rid the subsequent offspring completely of that risk, because you don't know what to screen in the male and what to screen in the donor. So when you do have monogenic disorders, and you do know that, let's say, the woman is affected and maybe the man is the carrier as well, and they've had multiple goes at PGS and it hasn't helped, and then they are using an egg donor, you definitely want to look at that monogenic disorder in the egg donor as well, when you want to proceed with another IVF. But here we don't know what we are looking for, and how those, even if we knew, we don't know how those points or things interact. So it is just a counseling way where one says that the chance of having an autistic child, with another go at IVF, or I don't know why they had an IVF, but maybe with another go, is not 100%. The risks might be maybe slightly higher than the general population, but that is a risk that one will have to be willing to undertake. Or maybe you could lower the risk with egg donor, but that doesn't go zero. So, I mean, I wouldn't offer an IVF only with a PGS cycle only to detect autism, is what I'm saying.
Dr. Richa, you are there? Dr. Richa?
Yes, sir. Yes, sir.
I just want to ask you something very different from this discussion.
Okay.
How difficult it is to look after an autistic child from a counselor point of view?
It is really very difficult, sir. Very difficult. It is one responsibility which comes on the shoulder of whole family. And we, like in my family, there is a child who is an autistic child. I can really understand the pain of parents they go through. It is really, really very, although there are many counseling techniques which we can use to deal with them, but then too, it becomes really very difficult to deal with them. It is just, a burden a parent is carrying. I'm so sorry I'm using this word, but it is really a burden for the parents. Whenever they have to move out, either they are going by plane or they are going by train or by car, they have to carry a help with them because they already have 2 more children to look after. And as it has been discussed, whether to go ahead, because that child was the first child in the family. So then after that, parents had the courage to, girl had the courage to deliver 2 more children after that. And she was totally shaken throughout the 9 months of her pregnancy, like whether if this thing happened. And then again, she got the guts to take another chance. And in between the cycle, it was told that there is some genetic problem which is seen. But then too, she went ahead with the thing, because she didn't want to, abort the child. And by God's grace, everything was fine. She was blessed with a baby boy and he's doing very well. But then for your question, it is very difficult to...
Positive story, Doctor.
Sir, I also, I would say that autism is on the rise. And he said that we really don't know why it is on the rise, but it is I've interacted with a lot of pediatricians having had an autistic child in one of our pregnancies, surrogate pregnancies also. So, and detecting an autism is also, because it is, I think, not so easy in the beginning when the child is socially awkward and you are really, not sure. And most of the pediatricians also admitted that, it's the developmental counselors or the developmental pediatricians who will be the right person. And even the normal pediatricians sometimes are not able to pick up an autistic child in the beginning. And they say that if you treat them from the beginning and they can help, that can probably help, including carnitine. And there are some of the products that are now coming up which can help autism. But, rising paternal age and sperm defects that they are saying are now coming up in a big way. And in fact, some of the studies also showed IVF to be one of the reasons for rising, although most studies have, not supported that. But all in all, I think it's a grave scenario.
Dr. Sophia, she is there, ma'am? Dr. Sophia?
Sorry, I was muted. Yes, I'm
Yeah,
here.
okay, sorry. I want to know what is the update from you, from any update about management of autism in UK? Anything new?
Well, as Dr. So autism is indeed increasing. We'll know it's a multifaceted condition. So there's, we can say it's only from a genetic origin. There's multiple determinants that affect not only its presence, but also the spectrum. We know there's a lot of variability and there's cases that, are even not detectable because they're or very hard to detect because they're, they're not extreme. In the UK, there's a lot of work about helping autistic children to develop social competence so that they can better interact with others, because that is one aspect that's really affected when you're an autistic child, the ability to look at other people and look at their faces and understand their emotions and react in a adequate way to that. So the social aspect is very, very important, and it's very worked in the UK. And then there's also work to try to minimize. So another difficulty of autistic children is that any kind of stimulus can be very upsetting and disruptor. And so to give them tools to try to manage those skills or to attenuate those skills. And there's also even technological solutions coming up, like little glasses that help autistic children navigate different types of environment, glasses that give them information that are, for instance, being developed by Google in collaboration with scientists. So there's a lot of work in different areas.
Thank you, ma'am. It has been really informative to us because we want to know what is happening in UK about this problem, which is increasing here also. We go to the next case scenario, empty follicle syndrome. 28-year-old lady with anovulatory cycle, previously failed IUI, stimulated with antagonist fixed protocol. After 10 days of injection, when the majority of follicles are more than 18 millimeter, E2 was 2,800 picogram, expected follicles were 20, and agonist trigger was given, and OPU done 35 hours after trigger, and no oocytes were retrieved. The couple was informed about the unfortunate event, and they were understandably saddened and agonized to hear the news. What is the counseling role before the next IVF cycle? Dr. Surjit, how you will deal with such a patient? Dr. Surjit is there? Hello? Hello?
Yes, I am audible. I am audible, Sandra?
Yeah.
So, she's a young 28-year-old girl. So having anovulatory cycles on failed IUIs and good folliculogenesis after giving the injections and good steroidogenesis. But after the trigger, she has not responded. There is no oocyte recovery. So this is an empty follicular syndrome. This is a quite bad experience, and for the physician and for the patient also, to know that there are no oocytes. So this can be, this is the incidence 0.4 to 7%, and there can be false empty follicular syndrome. There can be genuine empty follicular syndrome, or 3-4 times this is a false empty follicular syndrome, which can be corrected. So first the lady, we will like to see what can be the causes, and for the anovulatory cycles, what are the hormones level on day 2 or 3. If the hormone levels are very low, then she can be a case of hypogonadism or hypothalamic amenorrhea with PCOD morphology, giving the false impression of PCOD. So in such cases, the agonist trigger will not work, because agonist trigger will work from the pituitary and GnRHA will act and the FSH-LH will be released as a natural surge. So first we have to think what type of case that is, or secondly, this can be a case of polycystic ovaries also, or because cycles were anovulatory, that we can also judge from the hormonal levels. And after giving the injections, he has developed 20 follicles. The number is good, and E2 is also normal, but still the agonist has not worked in this case. So there can be many causes, genuine causes also. In the PCOD, there can be defects in the folliculogenesis from the starting. Follicular atresia can be there, and for other causes we can think that false causes we can see that timing of the trigger that can be faulty, that can be mistaken or wrongly given by the staff, or the medicine that can be bioactivity low or not properly managed, not properly packaged, and cold chain maintained. So if there is or very important is a time difference between the antagonist and agonist. So it should be minimum more than 6 to 8 hours. And ideally it should be 12 hours, so that the pituitary HPO axis that gets released from the antagonist effect and the agonist effect comes. This can also be the cause of the failure of this trigger. And then when we have to think of that counseling her for the we can counsel her, we will change the protocol, and in the next cycle we can give her dual trigger or dual trigger, HCG and agonist both. So agonist will cause the natural flare of FSH and LH, and HCG will take care of the corpus luteum. So that can be effective. Or the dose of the trigger can also be increased. It can be 20,000 we can give. And secondly, or we have to be very cautious. Once we have given the trigger, and we can check the hormone levels after the trigger, after 12 hours, LH should be more than 15, and progesterone level, it should be more than 3.5. So we can expect the good outcome.
Has been excellent explanation for this MP follicle syndrome. Dr. Anupama.
Yes, sir.
You see, we will shut down right now because Dr. Sophia is waiting. She has to give a talk. We have got 2 more questions left. We will first invite Dr. Sophia to give her talk. After she finishes it, we'll see if we can take up these 2 case scenarios. So let us all welcome Dr. Sophia to give her talk, because she is waiting for them for quite some time.
Hi.
Yeah.
Thank you. Thanks. That's very kind.
Yeah, Dr. Sophia, please.
I would request Pramila ma'am to introduce Sophia ma'am, please.
Good evening, everyone. First of all, I'd like to thank IFS for inviting me to chair this session. It's my proud privilege to invite Dr. Sophia for a talk. She is an internationally recognized academician whose work aims to support people in all steps of achieving their parenthood, gains, or when this proves impossible, in coming to terms with an unfulfilled wish for children. She conducts research and publishes in the best post-review journals on the topic. She trains healthcare professionals worldwide and participates in multiple events to raise awareness about the emotional aspects of infertility. She chaired the first European evidence-based guidelines for delivering routine parent psychological care at fertility clinics, has been on the editorial boards of Human Reproduction and Fertility and Sterility, and coordinated the psychology and counseling special interest group of the ESHRE. She's a certified clinical psychologist and a senior lecturer in health psychology at Cardiff University. Welcome, Dr. Sophia.
Thank you so much. It's a great pleasure to be here today. Can I, before I start talking, can I share my slides?
Yeah.
Okay. So can you all see my slides?
Yes, yes.
Yes, I'm just, okay, so today I was asked to talk about when everything fails and how can we support those patients who go through all the treatment period and are not able to have the children they wished for when they finish. And this, of course, can happen due to multiple reasons. Age, poor prognosis, repeated failure, lack of financial access to treatment, etc., etc. And we know overall that around at least 2/3 of patients will finish a treatment process. Sorry, 1/3 of patients will finish a treatment process without having children. So in a way, what I'm going to talk about is the online support that we developed here in the UK very recently in the format of a web app that's called My Journey. And I will be presenting the app and also the development process and research process behind the app. So, of course, we know that many women and men reach the end of their reproductive life without children. In the UK, that's 1 in 5 women and 1 in 4 men. And we also know that the majority of people who are childless, they are not childless by choice. So 90% of people who are childless do not want to be in that situation. We also know that around 1/3 of patients who do fertility treatment end the treatment without having the children they wished for. And it's a general trend in the UK, in Europe and worldwide, that people are having children later in life and are starting to build their families later in life. And the result of that is that there are increasingly more people who are childless, but also people who have children but don't have all the children they would like to have and therefore continue to suffer because of that. We also know that those people who sustain a desire for children have worse mental health than those who don't have that desire. And this graph here shows in gray the people who have a desire to have more children. Here on the right are people who don't have children at all. In the gray, these people want to have children. These don't. And you can see that their mental health is severely impaired. And also on average, it's below the cutoff for clinical significant problems. So on average, these people will have worse mental health, and it will be in the realm where we can say that they may have some mental health disorder. What we also see for those people who have children, those who still want more children also have their mental health affected significantly, although not as badly as those who don't have children at all. So not realizing one's desire for children has a significant impact on mental health. And really it was this study that kind of started for me, from my perspective, the whole work on supporting people after fertility treatment. And this is a very large sample of people from the Netherlands who did treatment and were not successful with treatment. So we also know, and increasingly in terms of policy, more societies and scientific organizations worldwide have called for the importance of continuing to support people once they've exhausted their chances of having children, and that it's the clinic's responsibility to support their patients not only when they're attempting to have children, but also when they did treatment and were unsuccessful and then have to adjust to this reality. And but as awareness for the need for support after treatment is increasing, there's also a lot of evidence showing, and for instance, the ASHRAE guidelines, which I chaired in 2015, were published in 2015, showed that at the moment, there were no interventions identified and that had been evaluated about supporting people after unsuccessful treatment. And from my knowledge, since then, there was only one intervention developed in the Netherlands to do that, and now the one that we've developed. And so across, for instance, in the UK, more and more importance has been kind of attributed to the need to support patients once they finish treatment. So given this context, we set out to develop an intervention to support those who are not able to have children with treatment, but also it could be due to other life circumstances. For instance, many women end up not having children because they never find who they consider to be the right partner to have children with. But so in this development process, we have followed recommendations from the UK Medical Research Council. So when you're developing psychological interventions, the advice is that you do a phased development, where in stage one, you look deeply into what could be the theory behind your intervention. And then you start to transform that theory into the components of your intervention, those components that you expect will create the change that you desire in your patients. Then you kind of do an exploratory trial where you want to see if the intervention is accepted. So if people like to use it, and if it's feasible, if it's possible to use it in the format that you're offering. And only after will you go and test its efficacy, if it's really producing the change you would like to. And also if you kind of want to then disseminate it to other contexts, other countries, other cultures, etc. What would you have to do if you have to do something to adapt it to all those differences? And so our work so far is here on, and we have developed work until the stage 3. We started by doing a lot of studies about the theory, and I'm going to talk about this. We then, based on the theory, developed our components and have been doing several studies and kind of an iterative process until we've now developed the app that's available online, and we're running a feasibility RCT to see if people are using it and how are they using it, and we will look at the way they use it and the impact it has on their well-being. So to start to talk about the theory. So when we first realized, and basically from the study that I showed, that not realizing an unfulfilled child wish had such a strong impact, we also started to ask ourselves, how do people adjust to this? And to try to answer that question, we basically did a systematic review of all the literature that had been published until the moment on this topic, which we then published in Human Reproduction Update, but in a very kind of simple way. What we found was that there were 3 domains of adjustment. So individually, and as I already said before, when you don't realize your parenthood dreams, you go through a profound process of grief that is comparable to the loss of a child. And this process is very intense and can also be prolonged in time. On average, it takes around 2 years for people to adjust to this loss. And we'll talk more about this, but at the social level, it is a lonely experience. People tend to feel isolated and not understood in their suffering, also because it's an invisible loss. So many people may not even realize that you're going through this process. And at the same time, people, in a way, they almost self-exclude for what they call the fertile world, because it's very painful to be in situations where other children may also be, and you have your loss kind of re-experienced constantly. What we also saw was that patients going through this process, or ex-patients going through this process, felt completely abandoned by the clinic. So from the moment they stopped trying, they felt that there was no support to go through this very painful experience. At the same time, they thought that this is precisely one period where psychosocial support would be extremely useful because of the intensity of the feelings, and also because of the feeling of kind of dread when they try to look at the future and they can't really see what is there for them and what kind of person they can be. What this review also showed, and that we kind of based our theoretical model of adjustment, was that those people who adjust better underwent three main kind of psychological tasks. And one we labeled meaning making, and this has to do about people trying to answer the question of why is this happening to me? And now that I'm in this situation, what kind of person can I still be, even if I don't have the children that I'm expecting to have? And what kind of life can I construct that is still meaningful and hopeful? The other psychological kind of tasks that they underwent, we labeled acceptance, and has to do with an ability to live with those difficult reactions that they experience, to live with the pain, to live with the suffering, and understand that in a way these are emotions that are part of their experience and that they will tend to be re-experienced in the future. For instance, when their friends become grandparents and they don't, but that it's possible to live with this situation, with these feelings, and still have a fulfilling life. And then also it's the task of then challenging their life into new goals that, you know, are also fulfilling. They're not the goals that they initially wanted to live, but there can be other meaningful goals in life. So based on this theory, just to say that we also then empirically tested this theory, and I'm not going to spend time on this slide, but it's just to show that we tested the theory, and these are the three tasks here that I just talked. And our studies show that these tasks and the people who engage in these tasks do report better mental health and better well-being, different types of well-being. So there's empirical support for the theory. So once we kind of established our theory of adjustment, what we did to start developing our intervention or the app was to develop different therapeutic techniques, basically based on acceptance and commitment therapy, that would help people and just prompt people into engaging with these three tasks. And so for meaning making, we focused on value clarification, which has to do with understanding what's important for people in life, and also to try to see the positives in, or to give as much importance to the positives in a difficult situation as people usually focus on the negative ones. And then we kind of gave the focus on giving people skills to help endure and live with difficult situations and uncomfortable thoughts and stressful thoughts, and still prompt them to maybe face situations where these thoughts might be prompted or might be triggered more often. And then also, once you clarify what's important to you in life, and what a meaningful life for you means, how can you transform that in new goals for you to pursue, and how can you put efforts into pursuing those goals? And so that's based on this, we developed our first version of the intervention, and then we did an in-depth study where we asked people to use the intervention for 8 weeks, and we interviewed them at the start of where they first kind of had access to the intervention, and then when they stopped using the intervention. And overall, they found that the intervention was helpful and useful, that there was a kind of a structured process to work through that facilitated their grief process, and that they did perceive the benefits that we kind of hypothesized that there would be there. They thought the intervention was overall comprehensive and appropriate, was very accessible, easy to use, and most of them use them individually. And of course, most of our users were women. We didn't have so many men using the intervention. And one of the aspects that they said was that there should be more attention paid to how we connect with others in a way in response to that social isolation. And so then we used this feedback and we developed a new version where we integrated their feedback, and examples was all people going through this process talked about their experience as being a journey. And this is a metaphor very used within fertility, our journey to have children, but also our journey then to adapt when we are not able to. We talked a lot about still improving design and trying to make the intervention really inclusive. We added mindfulness exercises and lots of advice and routines, and then we specifically focused on how to connect with others. And so we based our whole intervention on the concept, on the metaphor of the journey. And that's why we call the intervention My Journey. And also because it's a web app, something that's going to be on your phone. And we don't want people to feel that their privacy is violated. So if you see something on the phone that says My Journey, it has nothing to do with trying to have children or not being able to have children. And that's an important thing for users. And so the whole app was kind of based on this idea. And because we know that the metaphor of journey is empowering for people who are going through this experience, gives them a sense of control. It's also consistent with this idea that this is a process that unfolds over time, and it's time is needed to go through the experience of grief, and that it would promote adherence to the intervention. And people think that overall users thought that support would be more helpful if it was provided at the start of everyone's journey. And that how we provide support really kind of provided a map to go through this experience. So what does My Journey offer? Basically, there's two sections in the intervention. One is the map and another one is the backpack. And the map, what it has is this succession of steps. Each step is one of the psychological tasks that I've mentioned before, and users are recommended to do one task per week, but also we give them the opportunity to just do it at their own pace. And this is something they really talked about, that people have different paces, and it's important to respect that and support that. And then once they do each step, they have kind of what we call routines that are unlocked in their backpack. And basically, these are more kind of small style exercises that help them to engage with the skills that they are learning along that week, and gives them suggestions for routinely practicing those skills. And that's why we call them routines. So this is what they see when they go into the app. They see this succession of steps, and all the steps kind of depart from the metaphor of My Journey, but they do focus on the different psychological tasks that we talk. So for instance, step 2 focus on self-compassion, how to be kind with yourself when you're dealing with different difficult emotions and steps, and etc., the different steps that I talked about. And then in both steps and routines, the kind of exercise that we have there can be writing and journaling exercises. We all know there's a lot of psychological evidence for the benefit of journaling. Mindfulness meditations that focus on the specific skills that we give at each step. They're not general. Each mindful meditation, it's about that specific skill that we're practicing. And again, there's a lot of evidence for the benefit of mindfulness. And then there's other examples and little kind of step-by-step exercises so that they can engage with that exercise routinely. And of course, suggestions to how to do these exercises with significant others. And this can be a partner, but can be a friend, can be whoever they think it's more suitable. Another important aspect of the intervention is that it asks people to report on their well-being at the start of each step, and then they get advice on what their score means. And when people have low scores, they can also be advised to seek more specialized support. So we know that this is kind of the first line of stepwise support, and those people who may be experiencing more extreme difficulties will need to get access to specialized support. And so we want to promote them to actually go and seek for that support. So in conclusion, this intervention was based on an extensive research work on how people adjust to unfulfilled child wish. It's based on contextual cognitive behavioral therapies that have received a lot of empirical support for more than a decade now. And there was an interactive process where we constantly engaged with users and different health professionals, patient advocates, etc., so that we developed in the end an app that really fitted their needs and preferences. But at the same time, we also made we were so very careful to try to meet certain values that we thought were essential. One, that the app was empathic towards this experience, that it was widely accessible, that it was inclusive and not for profit, so it's available for free, and also deeply informed by research and evidence. I just wanted to kind of inform that we are now running a feasibility study. This is a 2-arm RCT, and people are either randomly allocated to the intervention group or to a waitlist control group. If they are allocated to the intervention group, they have to fill a survey, then they have access to My Journey for 10 weeks, and then they're asked to fill another survey after 10 weeks. They continue to have the access that they want to My Journey as they can use it as their own kind of willingness. And then 6 months after, we again ask them to fill another survey to kind of try to look at the longer term benefits. If people are allocated to the waitlist control group, they fill a survey, a baseline survey, but then they don't get access to the intervention. And after 10 weeks, they fill another survey, and then they can get access to the intervention and use it as they want. And so after this trial, we will have really clear evidence about how people are using the app and the benefits that they may be experiencing. Now, this app is currently available in 2 languages because it was sponsored by both the Portuguese and the UK charities. So they're available in Portuguese and in English, but we're open to any kind of partnerships to translate it to other languages. And we've built the app so that it could be really easily translated. And what do fertility clinics need to know? Well, one, they can offer My Journey to those patients who are finishing treatment. Patients do feel that My Journey is most helpful when they are at the start of their journey. So shortly after the end of treatment could be a right time for them to consider it. The journey in it, the app in itself kind of helps them go through the process because it provides them structure, and this is from their perspective. But there is an acknowledgement that there will be individual variability in readiness to use. Some people will want to use it immediately. Some people will feel that they're not yet ready to kind of consider even the hypothesis or the reality that they may not have children. So we suggest that clinics can offer it as a useful resource that patients can consider when they feel ready. That's how we think it should be offered, and this could be in a flyer format or just signposting to the clinic to the website. And the clinics could integrate a link in their website if they have a section on psychosocial support. But also fertility counselors and psychologists who counsel patients through this process, and we work together with counselors to this goal, can use My Journey as a kind of complement to their counseling sessions with their patients. They can either kind of use My Journey to provide that structure, almost like an intervention protocol, or just as a complement where, they can go home and do a step as a kind of homework activity and come back and discuss it. And I know I've gone over my time, so I just wanted to acknowledge my two colleagues who were deeply involved in the development of My Journey. You can go to My Journey PT if you want to look at the website. It's available at the moment. It is only available, the app is only available for people who are willing to participate in the feasibility trial, but it will be available for free to everyone once the trial is over. And I'm very happy to answer any questions that people may have.
Thank you so much, Dr. Sophia, ma'am. It was indeed a wonderful lecture, and great work is being done by you promoting this app. I would request Ratan Boli, ma'am, to please conclude, give the concluding remarks to the lecture, and Dr. Gauri, ma'am, again for the concluding remarks. Thank you, ma'am.
Okay, I just have a question to Dr. Sophia. I was listening to her talk, and there was a mention of mindfulness of meditation.
Yes.
You see, because in India, we have a lot of work being done on meditation and yoga and this thing.
I know, and indeed that's where it all started, isn't it? This is just the Western countries kind of appropriating themselves of these very ancient practices.
So how do you take it and your this as a step in your journey, meditation?
Could you repeat the question? Sorry.
Yeah, how do you take it further, this meditation part?
So what we did in our app is that we made it, the meditations that we developed, they are specific to the things that we know psychologically help people through this process. So we have meditations, for instance, about stimulating positive reappraisal coping. And that is just like it's a coping skill that we know it's associated to just better well-being, but also more kind of optimism towards the future. And basically it's just prompting people to, whenever we are in difficult situations, those situations are difficult because they have a lot of negative aspects to it, but they can also have positive aspects. For instance, we can go stronger for going through that situation. We can learn new things about ourselves and our resilience. We can know new things about how the world works, etc. And when we focus as much as on these positive things as we focus on the negatives, that helps people going through those situations. It makes them more tolerable. So there's a lot of evidence, for instance, about this particular skill, but there's many other skills that we covered. So what we did was we did a lot of mindfulness exercises that would focus on each of these skills, and how while people were doing the meditations, they were also being guided on how to do these skills. And then once they are guided, they more easily can do them by themselves.
That's great. By what time do you think this protocol of this journey will be available free to everybody?
So the journey is the web app. If you just put it on your phone, myjourney.pt, everyone has access to it. Right now we're doing a study, so people can use it, but they have to participate in the study. And again, they can use it for free as long as they participate in the study. The study is scheduled to finish around July. And then at that moment, everyone can continue using it without having to enroll in the study.
Thank you, ma'am. Thank you.
I would request Gauri ma'am to give the concluding remarks and Anupama ma'am to give vote of thanks.
I guess Dr. Pratibha is going to talk something. Dr. Pramila, you are muted.
I just wanted to ask Dr. Sophia a question. If the couple has failed all treatment for infertility, suggesting adoption to them will heal their emotional well-being, will improve. And we have seen so many examples when they adopt a child, sometimes they just conceive naturally because their mental stress and they're emotionally more stable. Without any treatment, they conceive. So what is your opinion on that?
I think, of course, people, what we know from infertile couples is that, of course, they who do treatment, so people who do treatment, it's because they highly value the genetic link to the child. And after treatment, the research shows that only a small percentage of patients actually choose to pursue adoption. Now, this is a very personal choice, and it's right for some people. It's not right for other people. It's, only them can know according to their own personal values. We know that, of course, those people who have children through adoption develop very strong, healthy relationships with their children, and they are as happy as people who have genetic related children. So, adoption is as a valid option to become a parent as any other. But some people feel that it's not the right option for them. And that's, that's right. It's their life. Now, we also know that at the end of the treatment, those people who pursue adoption, because many times adoption is also not a fast, easy process. And so the type of struggles that they have during treatment and the psychological adjustment difficulties that they have continue when they're pursuing adoption. And they're also, they also deplete your psychological resources in a way. So just to say that, in a way, of course, it's a more than valid option. Many people, many people in the world choose it, but within the population of people who do fertility treatment, it tends to be a smaller proportion. Those who do go through the process and get to have children are very happy, but going through the process in itself, it's also demanding, just like going through fertility treatment.
Thank you.
Dr. Katie, do you want to continue with the panel, or shall I wind up?
Dr. Pune will just say thanks to Dr. Sophia.
I just want to thank you, Dr. Sophia. I was really looking forward to hearing you because I've read a lot of your work, and a lot of our work is along those guidelines only, psychosocial care and all that. That's wonderful.
Thank you. And it was a pleasure to be here. I'm happy to engage in all kinds of discussions, and I'm happy also to know that my work, has gone far in the world. I hope you found the topic interesting. May I ask a question from your kind of, the practitioner's perspective? Do you feel that at the end of treatment, directing people to an online support as a kind of first support would be helpful? Or you think that it would be better to what's your experience of dealing with people who are ending treatment and may need support?
I
Would be a great help.
Yeah, I think online would be a really great help. It would give them a feeling of self-confidence and self-control also.
Many of them, Dr. Sophia, might opt for, the local counseling, but some of them, yes, they do go in for the online counseling, advice. Yes.
Actually, ma'am, after the end,
lecture, Dr. Sophia.
After the end of this treatment, people are felt very betrayed and very depressed. So obviously, this is a very good forum if we can direct it to this channel, because they don't want to come for follow-up with the doctors.
Yeah.
They don't want to come to meet to the hospital, and they don't want to come to visit to the hospital. So I think this is a very good forum that if somebody can connect them online and counsel and support them. So can you please, ma'am, send the link maybe in the chat box so that we can help our, direct the
Yes,
patients or direct the
it was
person.
at the, I can put it, should I put it for everyone?
Yeah.
All panelists. So it's just my journey. myjourney.pt. There. Yeah, it's our experience also that although patients need support, they find it very hard to go back to the clinics where they went through all the treatment to access that support. And that was also something that, that also convinced us that actually giving them support online as a first step would be maybe a good option.
So, Doctor, thank you, Dr. Sophia.
Thank you. Thanks for the kind invitation. And I hope your meeting continues to go well.
Yeah.
Dr. KD, do you want to continue with the panel?
No, let's finish.
Let's finish? Okay. Yeah. It was indeed a very fruitful workshop with so many eminent national and international speakers speaking about the counseling. And counseling plays a complementary role not only in ART, even in routine infertility. There is so much of psychosocial stigmata in them. And we have learned from the different speakers how they should understand their emotional need of understanding the childlessness, giving information, and ensuring if it is processed, what are the implications of counseling, how we should select the words, and how we should have a body language to convey it to them. And now, to top it all, Dr. Gamero has guided us that you can go in for a online counseling forum also. So I think this is the place where so many counselors are logged in. I would request Poonam, like they have mental health professionals of ASRM, they have International Infertility Counseling Organization and British Infertility Counselors Organization. So we can have a sort of a counselors, sort of the SIG taking a sort of a forum to involved in such studies so that the counseling system in India as a whole improves. So with that, I say thanks to all of you, and I ask Dr. Priya Varshney to give Anupama Bahadur to give the vote of thanks.
Thank you, ma'am. Thank you for your valuable inputs. It is my honor to give the vote of thanks. I'd like to thank Dr. Sudha Prasad, Dr. Neena Malhotra, Dr. K.D. Nair, sir, Dr. Umesh Jindal, Dr. Gauri Devi, ma'am, Dr. Poonam Nair, and my co-convener, Dr. Ritu Jain, for a brilliant workshop. I'd like to thank each and every participant and all our esteemed faculty for a very thought-provoking workshop on counseling in ART. We've had a great academic feast, and I would like to thank each one of you for making this a grand success. Thank you to our esteemed foreign faculty for having spared their valuable time on a Sunday afternoon or morning. I think it was in their place. Sorry for any lapses that occurred. There were a few glitches because of, the network connections, etc. We apologize for that. Thank you once again. Thank you, sir. Dr. KD, it was wonderful being with you. Thank you.
Thank you, Dr. Gauri.
Thank you, Dr. Poonam, for giving me a chance.
Yeah,
Thank you,
Priya,
Dr. KD.
thank you for beating me.
Thank you everyone for your inputs and for your time. And it was really a great meeting you all and share looking into your experiences. And yes, we are very sorry that we could not contact Sandra and Jones due to their technical problems, but we tried our best to make it possible. And Poonam ma'am, KD Nair sir, Gauri ma'am, thank you for everyone for your time and inputs.
And Priya,
Thank you, thank you, thank you.
You have to be patient with us because we are new to this way of, I am new to this way of.
No, ma'am, you will, you have done well and you will keep on doing the things as usual.
I'll be able to do it next time better, I'm sure.
So now we will be going to start a quiz actually at 6 o'clock, and we'll ask all the faculty members to share it between your fellows, your students, your researchers, so that they can join the quiz. And the quiz can be joined through this link, and the password of the quiz will be shared once the quiz starts at 6 o'clock. So I'll ask everyone, please share their links in their group so that all the persons can join the quiz for the prizes and everything. Very exciting prizes for that.
Right, you have to announce prizes. It's 10,000, 5,000, 2,000, and 3 prizes of 1,000.
So anyone has found any difficulty in joining the quiz, can you put me on my separate message. We have password will be active at 6:15 around, and quiz login can start at 6 o'clock. Niti, you can place the quiz link also in your groups, and you can ask the persons to join the quiz things out. Thank you everyone. With this,